Test 1 2. Check. Test.
The music. Testing 1 2 3 1 1 1 2 3. Testing mic 1 2 3 1 2 3. This is sixth Gulf Conference on Burns and Wound Management, second day. Testing mic 1 2 3 1 2 3 1 2 3. Good morning. Testing mic 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Good morning. This is 6th Gulf Conference on Burns and Wound Management, second day. Okay. Okay. Good morning. Testing mic 1, 2, 3, 1, 2, 3, 1, 2, 3. Testing mic 1, 2, 3, 1, 2, 3. Good morning. This is 6th Gulf Conference on Burns and Wound Management, second day. Need my second camera? Okay. Good morning. Oh, thank you. Many happy return, लेकिन टाइमिंग सारी
क्या हो गया और मैं
okay. Good morning. This is 6th Gulf Conference on Burns and Wound Management, second day. Good morning. This is 6th Gulf Conference on Burns and Wound Management, second day. Testing mic 1, 2, 3, 1, 2, 3. Testing mic 1, 2, 3. Testing mic 1, 2, 3, 1, 2, 3, 1, 2, 3, 3. Okay, Puneet bhai. Mic 1, 2, 3, 1, 2, 3. Good morning. This is 6th Gulf Conference on Burns and Wound Management, second day. Good morning. This is 6th Gulf Conference on Burns and Wound Management. Testing mic 1, 2, 3, 1, 2, 3. The echo is there. Testing mic 1, 2, 3, 1, 2, 3. Testing mic 1, 2, 3. 1, 2, 3. Good morning. This is Sixth Gulf Conference on Burns and Wound Management, second day. Testing mic 1, 2, 3. 1, 2, 3. 1, 2, 3. Testing.
Check, check. A very good morning to everyone. As we say, God cannot be everywhere. So he sent doctors. With the help of your studies, hard work, dedication, researches, technology, and innovations that you all are using is extremely commendable. And with the help of all these things, you help us to turn our wounds into wisdom. Let's have a huge round of applause for all the doctors available today. I would like to now begin my day by thanking Dr. Marwan Al-Zaruni for having faith in me and believing in me and giving me this wondrous opportunity. Humble thanks to you, sir. Good morning, ladies and gentlemen. Welcome to the 6th Gulf Conference on Burns and Wounds Management 2022. I'm your host for the day, Sanjeevni Sharma. We shall now begin with our session 1. And may I please have the opportunity to welcome Dr. Valerio Carvelli and address the gathering. Humble thanks for joining us, sir.
Thank you very much. And I would like again to thank Dr. Marwan and Dr. Safwat for inviting us in this very wonderful town that is Dubai. And thank you to Dr. Claudio Ligresti, my mentor, and he is the director of the Italian Academy of Wound Care. I introduce myself. I work in the department, and I work for the Department of Plastic Surgery in the University of Rome, Tor Vergata. And let's go on and have the pleasure to introduce Dr. Claudio Ligresti for the introduction of this section 1 this day about case presentation. Please, Claudio.
Well, thank you. Good morning, everybody, ladies and gentlemen, and thank you to the moderator and Dr. Marwan for the organization. Again, thank you for kind hospitality. And the introduction about the causes of necrosis in wound care. Well, before I like to speak about the different concepts of cell death, because the apoptosis often provide beneficial effects for the body dying cells, send the chemical signals to the immune systems with the subsequent phagocytosis of dead cells and also elimination of debris. Instead, the necrosis is the result of the denaturation of intracellular proteins and the enzymatic digestion of the lately damaged cells. Cells rupture causes fluid to lead outside, resulting in inflammation. Causes of skin necrosis, well, are famous: pressure by ischemia, reduction arterial flow, infection, coagulative action, inflammation with enzymatic coagulation action, trauma, about crash syndrome, and cancer with enzymatic activity. But there are different causes, direct or indirect. Direct with the compression, crash, pulping, sunburn, rise, and burns. Indirect, lack of blood, lack of oxygen, impaired innervation. About the histologic events, we have increase in cell size with the production of swelling. The enlargement of the cells is due to the increase in water content resulting from the loss of integrity of the membrane. And that can produce the release of dairy contaminants, like, for example, enzymes, like proteases. It all produced finally the inflammatory phases in the wound. Apart the more common causes of necrosis and of infection, I like to remind you about some particularly causes of necrosis in the skin for the vascular occlusion, like antiphospholipid antibody syndrome, cryoglobulinemia, cholesterol crystal embolization syndrome, calciphylaxis. It's a rare, dangerous syndrome characterized by calcification of blood vessels and therefore the appearance of progressive and painful ulcers. Necrotizing vasculitis includes a number of the disorders that cause inflammation of the blood vessels walls, and alteration of hemostasis is a very, very dangerous syndrome. Other special necrotizing infections, like ecthyma, is a bacterial infection that causes ulceration and scabs, or necrotizing fasciitis, or gas gangrene, like muscle infection with a very fast course. It can even lead to death, or acute meningococcemia. But I like to remind you the infection is very, very dangerous for the wound ulcers. And I remind you the particularly bacterial infection, like alpha hemolytic viridans streptococci. Depending on the depth of invasion, necrotizing soft tissue infections can cause extensive local tissue destruction, tissue necrosis, systemic toxicity, and even death. Necrosis by drugs, of course. Just yesterday, we spoke about the necrosis by drugs. And I repeat about the use of heparin and, for example, noradrenaline, because heparin and warfarin induced the skin necrosis in patients who have congenital or acquired the deficiency of protein C, protein S, and occasionally in patients with paroxysmal nocturnal hemoglobinuria. The symptoms more common are eruptions, necrosis, pain, and erythema. Histopathologic findings show intravascular thrombi within superficial vessels. Classification of necrosis: dry, black with eschar; moist, black with brown eschar; slough, mixed, maceration, and fibrosis. It's very important to assess about the necrosis, because the necrosis is different. But it is always appropriate to practice aggressive debridement. Depend about the clinical case needed to be selected. Of course, how to decide when and how to eliminate necrosis. We know the treatment of necrosis depends on chemical, mechanical, surgical necrosis with scalpel, scissors, curettes, with radiosurgical unit or with ultrasound. But it depends the level and the depth of necrosis and the causes of necrosis. And so the assessed and the evolution of necrosis is very important. And Achilles tendon is, in this case, is an extrusion and the exposure of Achilles tendon. Immediate surgical exploration is needed. And so thank you for your attention.
Thank you very much, Claudio, for this introduction about the cause and the problematic of necrosis. That I want to underline that is a pathology that regards especially poor people, because people very well informed about the problematic and the high social level in difficult case can reach a situation so important. So that is a real, very important social reason that ask us to put attention to this particular problem. Now, I think we have Giacomo Clerici in contact with us.
Can you hear me, Valerio?
Giacomo, we hear you. Okay.
Okay, perfect. I try
And
to share my screen.
now you have 5 minutes to introduce us this first clinical case about the necrotic diabetic foot. Please.
Okay, can you see my slide?
Yeah.
Okay, thank you. Ladies and gentlemen, colleagues, chairperson, good morning again. Today I would like to talk to you about heel lesion gangrene of the heel, because heel ulcers usually are considered a severe pattern in patients with diabetes, and are in the main part of the cases responsible for major amputations. Approximately 20% ulcers in patients with CLTI occur in the heel, and is typically considered to be more problematic than forefoot ulcers for several reasons. In our experience, the location of the heel is such that any major lower limb amputation may preclude a patient from future ambulation. And when you have a forefoot amputation, is relatively less morbid and is likely to preserve ambulatory function. And also, the heel lesion has a unique single angiosome blood supply from the posterior tibial artery, sometimes through the peroneal artery. And this is in contrast to the forefoot, which has a multi-angiosome overlap. And so, just a second. Okay, so this is the patient's characteristics of the clinical case. 65 years old male, type 2 diabetes, hypertension, retinopathy, carotid stenosis, chronic kidney disease, and right Achilles tendon reconstruction in the 1996. We received these patients with this clinical picture. We have extensive gangrene of the heel with a lesion in the posterior part of the tuberosity, propped bone positive. You can see the widespread signs of infection, but also this patient has a TCPO2 very low, 17 millimeters of mercury. It means chronic limb-threatening ischemia, no pulses, rest pain, fever, and leukocytosis. So this is the angiogram. You can see that below the knee, we do not have any direct blood flow down to the foot through the anterior, posterior, or peroneal artery. We have just the peroneal artery in the proximal part. And MRI confirmed, the probe-to-bone test confirmed the presence of osteomyelitis of the posterior part of the tuberosity. So according to the International Working Group on the Diabetic Foot classification system, but also according to the IDSA classification system, this patient has a severe infection. It means that we have to think about an urgent hospital admission. As I told you yesterday, first step is always to resolve the infection, is to resolve the presence of infection. So emergent surgery is the first step. You have to remove everything is infected. And as you can see here, we have removed everything is infected, but we have also the ischemia. This is really important, the first step, and it is important when you think about a multidisciplinary team to have a surgeon with experience and interest in managing diabetic foot infections, but moreover, clinicians without adequate training in wound debridement should seek consultation from those more qualified for this task. And these statements are from the guidelines 2019, International Working Group on the Diabetic Foot. Of course, after the infection, we have to think about the ischemia. We have to revascularize this patient as soon as possible, and usually within the day after the urgent surgical debridement. And actually, if you look at here, we were very lucky because our interventional radiologist, through the peroneal artery, was able to restore a direct blood flow through the posterior branch of the peroneal artery to the heel area where we have the problem, where we have to think about surgery. Another important underestimated and overlooked treatment, offloading during the day when our patients walk and during the night, or when they are in the bed, in dialysis, etc. Important offloading. Offloading protect your work and preclude the problems with pressure. So after a few days, you can see that we were able to resolve the infection. We were able to resolve the ischemia, but we have another problem, the bone exposure and the osteomyelitis confirmed by the MRI. You can see here that from 17 millimeters of mercury, now we are 35 millimeters of mercury. So at this point, we thought about a partial calcanectomy. Think always biomechanics. It means that we have to think about a functional limb. Functional limb is the limb that you are able to put in a shoe with insoles, etc., at lower risk of new ulceration. And so, since we do not have any soft tissue for covering the bone exposure, we cover it with a dermal substitute. And you can see that after a few weeks, we cover it with the skin graft, and we have this kind of results after a few months. We started in February with this situation, and in July, we had a complete wound healing. Our work is not finished yet. We have to think that in our patients with diabetic foot, the risk of recurrences is really, really high. And so for this reason, we have to think about the stratification risk. These patients with a history of a foot ulcer or lower extremity amputation are at highest risk of new ulceration. This is the reason why the secondary prevention shoes and insole are mandatory, and follow-up visit every 2 months is a mandatory task according to the international guidelines. Thank you for your kind attention.
Very much, Giacomo. And I think due to the fact that he's in connection with us by Zoom, there is some question for Dr. Clerici. I have one question. I think is important, Giacomo, always to look after this patient, because otherwise, in case like this one, is very important to solve the problem without amputation. But as everyone knows, in this field, the amputation, the so-called the theory of salami, the salami means that the salami you can cut a slice by slice and lose your foot in more than one situation. So that is very important, as you told before, the prevention, because in the majority of cases they are not so lucky and they have probably to lose the foot. What kind of solution in this patient in which is not possible to solve the problem in a conservative way, but we need to the amputation?
Thank you for your question, Professor Cervelli. I agree with you. these patients are at very high risk of major amputation. And if you are not able to solve the infection problems or the ischemic infections problems, or when the gangrene is extensive and you cannot think about a minor amputation, but thinking biomechanics, thinking about a functional limb, of course, the only way you have to carry out a major amputation, because in many cases, you treat these patients for months and months with dressings, antibiotics, etc., and they risk sepsis, they risk more aggressive complications. So when it is possible, we try to do everything we can in order to save the limb, even achieved with minor amputation. But if there is no space, of course, think about a good major amputation, a good prosthesis, and maybe these could give the patients a new life.
Thank you very much. There is another question of Professor Bassetto.
Ciao Giacomo, I have a question for in your huge international experience, considering that you work in many departments that treat diabetic foot. Which is the percentage of, in your experience, that you decide to send the patient to a microsurgical team of plastic surgeons for a microsurgical reconstruction? Which is your percentage? Because I think that there is a huge question open on this point, still open.
Yeah, so we have done many, in 25 years, we have done many cooperations with plastic surgeons according to this task. Unfortunately, the space is very small, but not zero, because in some cases we have achieved very good results with the use of microflaps, latissimus dorsis, or other kind of flaps. And the reason why the space is very small is because of our patients are very old with many comorbidities, and you know that some of these interventions are interventions that you have to carry out for 5, 6, 7 hours. In many cases, like in these cases, you have just one patent artery treated by means of angioplasty, so not so good for you if you have to think about a flap. So the space is small, but when you have the right patient, when you have the opportunity, the results are amazing, even from a biomechanics point of view. Because, for example, in this case, if I would have considered these patients for a flap, should have been better, because these patients had a heel lesion in the plantar spector of the foot, and you know better than me that the risk of new ulceration is really high. Unfortunately, because of the clinical conditions, because of one vessel through the peroneal artery, I couldn't think about a flap. But flap would have been the perfect solution for this kind of patient.
Thank you.
Now, another question, a rapid question and a rapid answer. The Dr. Ligresti, please.
Giacomo, una domanda velocissima. How is important for you the offloading and the use of the good orthosis for the follower control in the diabetic surgical patients?
So 100% important, because you have to protect your work. Maybe you have done a very good job. Your interventional radiologist or vascular surgeon have done a very good work, and everything will be destroyed because you didn't choose a correct offloading device. So offloading is a key point, like revascularization is key point in patients with ischemia. Offloading is important 100%.
Thank you, Giacomo, for your very important contribution to this section. And now I have the pleasure to give the word to my friend Franco Bassetto. He's a full professor of plastic surgery in the University of Padua in Italy, and he has a double exposition, 5 minutes each one, no more, because otherwise we are going to go out of time. And the first one is about the surgical wound with necrosis, second clinical case, and the third clinical case, the necrosis by trauma. Please, Franco, 5 plus 5.
Thank you very much. We try to stay in the time. We can have some, unfortunately, some surprise after our procedure, our surgical procedure. The first is the necrosis in our surgical wounds. And I want to share with you some cases that sometimes could be very dramatic. This first is a female, 45 years old. She went through anchor abdominoplasty in a post-bariatric case with the presence of an hernia. So we decided to reconstruct her with an anchor abdominoplasty and with the use of a prosthesis, a surgical abdominal prosthesis, but unfortunately, exactly in the point where the linear surgical wound meets the horizontal one, we had this necrosis. Such case could be a dramatic case because we have to remove even our prosthesis, that it's not, fortunately, it was an artificial one, and so we decide then to put not to use it again. And fortunately, we were lucky because we know that in the abdominal area, we have a laxity, especially in post-bariatric patients, that permit to arrive to this final result, but unfortunately, we don't have the prosthesis. So maybe this patient will go on a recurrence of the hernia. Another condition is this. We are using now in Italy a lot of direct to implant in mastectomy in patients in which we use the prosthesis with the dermal substitute, that it's a very clever envelope. But when we have a necrosis of exactly of the area of the nipple, unfortunately, we have to remove everything. And so this is another case that could be very, very dangerous. So we have to consider the thickness of our flaps when we perform direct to implant reconstruction in mastectomy. And this is another case in which we decide with the necrosis of the areola and the nipple to perform a necrectomy and to use direct a dermal substitute. When the dermal substitute go on in times, we can solve the problem with skin graft, and then after at least 1 year, we can perform the nipple reconstruction and the use of tattoo for the CAC reconstruction. Another case is in hand surgery. The bone exposure in a fingertip could be really another tragedy for the plastic surgeon. Here we had the necrosis of the simple mobile flap that were used in emergency, and in such case the decision was necrectomy, the use of dermal substitute. We have Integra, we have many types of dermal, fortunately, and we are using now new one that the market is proposing. And then when we are sure that this dermal substitute was in a good condition, we can perform to a stable reconstruction that in such case was performed with an heterodigital flap. Or these cases that yesterday I mentioned it was a post-surgical abdominal necrosis in multi-drug resistance patients to a Serratia marcescens, that it's it's not it's really a tragedy, we know. So what we have used here, VAC installation. Yesterday during the discussion, many colleagues asked to me to explain better what we intend with installation. Installation is the last generation of a negative pressure that permit to use antiseptic solution. And with the use of antiseptic solution in a cyclic way, we can obtain bacterial we win our battle against bacteria, and then we can arrive to an elegant final solution. Or the use of fluorescent light energy, like in these patients that has a chronic ulcer related to the fact that it was treated with corticosteroids. In such patients, a banal trauma can develop a very resistant loss of substance that was resolved with fluorescent light energy. Thank you very much. The second title, it was necrosis related to trauma. We know that even in such case, we can have different kind of trauma and different kind of clinical condition. Here, I want to share some cases that can be very, very difficult for the daily practice of a plastic surgery team. This first was an accident that it was a car accident with a dramatic post-traumatic necrosis of the feet. What to do in such patients? As soon as possible, a huge debridement. It's very important to arrive to safe tissue before deciding what to do. Sometimes we have not the possibility to reconstruct immediately these patients after the debridement, after the amputation of half of its foot. And remember that we have microsurgery. As I discussed with Giacomo Clerici, in such patients with a trauma, young patients, maybe we have a very good condition, a vascular condition of the lower leg. And so studying it, we can decide which is the best pedicle for an elegant reconstruction with, and in such case, an ALT, that it's now our first choice in microsurgery procedure to decide to save the lower leg. Or going on, this is another patient with a post-traumatic leg ulcer. If a patient have a vasculopathy, we know that a banal trauma can cause a necrosis, and this necrosis become a chronic ulcer. What to do in such case? We use negative pressure with instillation. And in my own practice, I understood in the last years that using instillation, really the period of treatment is shorter. From the 3 weeks of normal negative pressure, we can reduce it to 1 week. And so the patient could be ready. What to do? A simple reconstruction with a skin graft or a more sophisticated reconstruction. It depends on singular condition. In such case, we have this patient has no enough subcutaneous adipose tissue. So we decide for a stable reconstruction in time that was performed even in such case in a young boy, in which we study his vascularization, the microsurgical procedure. So the answer, as Giacomo told, is that microsurgery must be carefully proposed to this patient if we have a vascularization that permit to us to use it. On the contrary, if we have some doubts, it's better to go on with MPT, installation, and then simple skin graft. Another patient, a post-traumatic necrosis with tendon exposure. Even in such case, we decide immediately to perform an microsurgical reconstruction because it was young, it was a patient with a good vascular condition of the lower leg, and surely the microsurgery is the most elegant and very stable in time reconstruction for lower leg. And here you can see what is at the end, after 5 months, what is the evolution in such phase. The heel, we have seen some diabetic foot cases with necrosis on the heel. This is a necrosis on the heel related to a trauma. And what was the decision? A simple way. First of all, a huge debridement. Now we are performing the different kinds, the surgically debridement, or even most the hydro debridement that is another option for a huge debridement, and then the reconstruction with a dermal substitute, and then after 3 weeks, skin grafts. And going on, if we go to that, it's what I love more because I have 40 seconds too. If I have a necrosis of the first thumb, you can see that we can perform interosseous posterior flap. That is a pedicle solution. I'm a hand surgeon too, and I love this clinical case. The last one, the use of negative pressure and microsurgery pressure. So in the last 7 seconds, I say that it was a wonderful experience for me to be here, and we hope that somebody of you come to Italy for the Academy of Wound Healing. You are welcome, and we can share our experience. Thank you very much.
Thank you. Now I introduce myself. There is a mistake in the program. My one clinical case presentation is about neoplastic necrosis, and I chose this particular man, a male patient with a family history of squamous cell carcinoma and dementia, and due to the problem of COVID pandemic, he went to our observation with a squamous cell carcinoma of the first finger. In April 2021, there is the appearance of this ulceration, distal phalanx of the nail bed of the left thumb, and the local treatment gave no result with a rapid progression, but the patient delayed the surgery because of the pandemic. And in another hospital, there was a simple surgical curettage and biopsy. And the result was squamous cell carcinoma. He presented to our department in this particular situation with a complete necrosis of the distal phalanx. And you can see also the invasion through the nail bed until the phalanx, with a total substitution of a soft tissue and bone erosion of the distal phalanx down to the articular surface that was even taken by this neoplastic disease. And the surgical planning was the amputation, obviously, of the distal and proximal phalanx down to the joint, rotation flap from the palmar skin to close the defect and cover the articular surface. Usually in this case, we use also the so-called fish mouth closure, but was not possible, or at least not convenient in a case like this one. And obviously, before the treatment, we were to do diagnosis for some lymphatic problem in the lymphatic station, but there was no appearance of problem in the lymphatic drainage from this from the hand in the axillary station. Obviously, the patient will be followed in the next month to do this and to see if there is some lymphatic metastasis. But this is the intraoperative image of the patient with the perfect closure of the lesion. And the pathology report was ulcerated squamous cell carcinoma, poorly differentiated G2, G3, with bone erosion and periosteal involvement, but there is a complete excision of the lesion with a quite good wound closure, with also an adequate residual function, free of focal distant recurrence at 6 months, but even after follower. The squamous cell carcinoma of the nail unit is often misdiagnosed, and there is a high index of suspicion if necessary. And there is more men than women having this problem, with a main patient age of 61 years. The incidence is 14 cases in 50,000 dermatological consultation. We had 3 cases in 250,000 hospital admission. The nail bed involved more often than the lateral, and the first finger is always, the majority of the case, the problem of the nail bed carcinoma. And the history of disease, there's an involvement of 50% of the cases, and an amputation is always necessary, with a quite high recurrence rate and a metastatic rate, 14.3%, with even high mortality. It's always required an amputation to solve the problem, and the level of the amputation is the interphalanx. The take-home message is that it's an insidious disease, and often the involvement is important, requiring a proximal amputation, as I told before. Thank you very much for your attention.
We shall now begin with our session 2, and can I have the honors of welcoming Dr. Muhammad Qadri.
Hello, good morning, everybody. Bismillah ar-Rahman ar-Rahim. I want to congratulate Marwan and the organizing committee for a most successful, in spite of all what's surrounding us, like COVID-19 and things like that. You had the courage and the gut to bring the conference in time. So thank you very much, and thank you very much for the attendance. We are a little bit late concerning this session, 10 minutes, so I would beg the speakers to stick to their time. A little bit change. Instead of Eduardo Gas, we're having Dr. Tarek El-Menoufi. Tarek El-Menoufi will give us his talk of post-burn neck contracture managed with supraclavicular artery flap. Our friend and colleague, Dr. Tarek El-Menoufi, he's working in the military academy in Burn Center, one of the oldest and the most well equipped and well-trained centers in the area. Father Dr. Tarek.
Okay, thank you, Professor Kadri, our professor. And again, I would like to give my thanks to the organizing committee. Thank you, Mr. Marwan, and thank you, Mr. Qahtani, and also my friend, we are meeting you, Ms. Dr. Safat Al-Husseini. My talk today is about the, Bismillah ar-Rahman ar-Rahim, the post-Burr neck contractures effectively managed with a supraclavicular artery flap. This is our Armed Forces Burn Center, where we practice. Neck contractures are very common sequelae after flame burns, scald injuries, and chemical burns. The skin in the neck region is thin and pliable in order to have a wide range of motion in 3 dimensions. Contractures of the neck is an extremely disabling condition. The neck develops a fixed flexion deformity with restricted extension and rotation. Scars in this area may lead not only to a restriction in the range of motion of the neck, but also to abnormal function of the face, lower face, such as lip incompetence and reduced facial expression. In developing a child below the age of 12 years, often end with mandible and cervical spine deformities, and drooping lower lip and dribbling of the saliva are not uncommon conditions associated with post-burn contractures. Delayed treatment, initial poor management of the burn, lack of a well-staffed and managed burn unit, and the longer-term outcome in burn patients are the main reasons for this problem. These contractions affect the patient significantly, causing both functional limitation and aesthetic disfigurement that lead to cosmetic, functional, and social problems. Due to these major complications, the multidirectional movements of the neck necessitate special consideration in its reconstruction. The challenge lies in the restoring the form and function of this region. Many methods have been advocated to release the contractions and provide soft tissue coverage, including skin grafts, zydplasty, local flap with or without tissue expansion, pedicle flap, and free flaps. Starting by skin grafts of these defects is a simple option, although it is a simple option, but it has limitation that large defects and movement of the neck cannot be restricted for good graft take. And also, graft have a secondary contraction, and this is aesthetically not accepted to the patient, especially for females. As regard local flaps can only be used for small defects and have an inadequate amount of tissue to cover the resultant defect after contracture release. Also, the use of pectoralis major trapezius latissimus dorsi as a musculocutaneous flaps have various advantages, but in this case, they are too voluminous, which can restrict the neck movement. As regards the supraclavicular artery flap, it is a local regiofacial-cutaneous flap taken from the skin on the shoulder and supraclavicular area. This flap, due to its satisfactory aesthetic results and the location far from the injury, provides a good alternative for reconstruction. The supraclavicular flap is thin, pliable, and color match is excellent. The thinness of the dermis permits suitable adaptation on tissue lines, and lack of hair make it suitable for females. This is the flap design and elevation. The flap is determined size according to the recipient site and the flap design of the patient's shoulder, as we see in this figure. If pedicle flap is made according to the condition of the recipient site, it's possible to harvest the flap up to 11 centimeters in width and 21 centimeters in length, allowing the anterior edge to reach the inferior border of the clavicle and the posterior edge to reach the upper border of trapezius and distal edge to reach the upper arm over the deltoid. The donor site can be closed, fortunately, primarily when the flap width is smaller than 10 centimeters, but when the donor site is over 10 centimeters in width, split thickness skin grafts are necessary. A Doppler flowmetry is useful for identifying the supraclavicular artery. The elevation of the flap. During the operation, the recipient site scars are debrided to the deep fascia to release all the contractures completely. The harvested flap includes skin, subcutaneous tissue, and fascia of the deltoid muscle. In the medial part of the flap, the supraclavicular artery arises from the transverse cervical artery. In most cases, can be identified. We can identify the artery in triangle created medially by the posterior margin of the sternocleidomastoid, inferiorly by the clavicle, and laterally by the external jugular vein, and we can confirm that by use of Doppler flowmetry. The skin island was marked and the flap was raised from the lateral area, from lateral to medial at the subfascial plane of the deltoid muscle until supraclavicular fossa. Lymph nodes and fat must be dissected and mobilized around the supraclavicular artery to attain greater arc of rotation. And this is also carried at the subfascial plane to guard the pedicle. As regards the accessory nerve, which present innervating the trapezius muscle, care also we should rest beneath the supraclavicular flap and its pedicle through it was in the deeper tissue plane. Dissection must be kept at the subfascial level to avoid injury of this nerve. The flap is rotated and inserted into the defect. The donor site closed primarily over a drain and after extensive undermining of the surrounding tissue in most cases. Otherwise, split thickness graft was applied. The defect site and the neck were also typically closed over a drain. After discharge in the recovery room ward, after discharge, patient was advised to sleep without a pillow under the head and instead use a small pillow under the shoulder blades. Regular flap monitoring. Skin graft was checked after 5 days and the graft donor addressed was after 3 weeks. The patient was regularly followed in the outpatient clinic and scar therapy was advised. Once the flap and graft were stable, usually after 14 days, regular full range of motion exercise of the neck and the shoulder was started. Patients were advised to wear a custom-made soft collar splint for 3 to 4 months. I show you some of our cases. This is the first case. Preoperatively, we can see an extensive post-burn contracted neck with extensive scarring. We decided to perform a supraclavicular artery flap for this patient. I'll show the video in a hurry for you. We are starting now to dissect the flap after putting our design in the supraclavicular area and over the deltoid. We should incise down to the fascia. We injected adrenaline solution 1 to 200,000 in order to achieve good hemostasis, give us a chance to do a proper dissection of the flap over the deltoid muscle, taking skin subcutaneous and fascia with us in the flap. We want to have a fasciocutaneous flap. Put a tie this stitch to allow to hold the flap to facilitate the process of dissection. As you see, we are going over the deltoid muscle, taking with us the skin, subcutaneous, and fascia. You can run the video faster for the time. This is the posterior border of the flap. Now we are encroaching the area where we find the pedicle. As you see, while we are going through the posterior part of the flap, we have to keep in the subfascial plane to protect the accessory nerve of the trapezius muscle. Here we try to dissect carefully as much as we can to increase the arc of rotation of the flap. This is the flap elevated with a good arc of rotation, and he can reach the other side of the neck. Now again, we inject adrenaline 1 to 200,000 to remove the deep scar tissue And we have to remove all the scar tissue to achieve good extension of the neck in order to have the advantage of making this flap to allow the patient to move the neck properly. We have to excise all the scar tissue in order to have a healthy tissue allowing full extension of the neck. And now we're inserting the flap and closing it. Okay, you can move to the next slide. Okay, you can move for the next slide. This is the patient after we finish the operation. You can see that he has a good appearance of the flap. You can move the video, please. Yes, this is the way can look good with good movement of the neck and good pliability of the flap. Okay, let's go for the next slide. This is another patient, again, extensive post-burn contracture of the neck, and he had a supraclavicular artery flap. Okay, next slide. I want you to run the video to show the end of the video. Yes, here we are dissecting nearly to expose the artery, and you will see the artery now, how we are exposing the artery in order to be sure that we have this axial artery with us in the flap. You can see I'm pointing to the artery now. This is the area where you can dissect around the fat. Okay. Yes, you can see the artery in this area. It's clear now. This is a good axial artery. Give you a chance to have a width and length of the flap up to 20 centimeters. Okay, the next slide, please. This is the patient. Okay, work the video. Play the video, please. He can do flexion, extension, and lateral right to the left. Okay, the next. Next, yes. This is the same, another case. This is the design of the flap. Next. Play the video. In this case, we have a wide donor site, cannot be closed primarily. We have put a skin graft to cover the donor site. Okay, next. Next. In conclusion, the thin and pliable skin of the neck is a region of multi-directional activity, and post-operative scar contractures tend to form there easily. Post-burn neck contracture is one of the most common burn sequelae. Patients with post-burn neck contractions frequently have marked limitations in neck mobility. Reconstruction of the neck is a quite difficult task because the scarring of the neck produces problem with function and appearance. A scar in this region easily noticeable. Soft tissue reconstruction of these defects can be done by skin grafts, local, regional, and free flaps. The supraclavicular artery is an excellent and effective choice for reconstruction of the soft tissue defect of the neck after release of post-burn contracture, with impressive recovery, acceptable skin color match, restoration of anatomic function at the recipient site. Donor site generally heal well with relatively good aesthetic acceptability. And finally, an additional advantage is that this skin can stretch post-operatively to allow further improvement of the neck contour and the mobility. If you can see the patients after 2 to 3 months, it has more movement of the neck because of the stretch of the skin. Thank you.
Thank you very much, Professor Tarek, for your nice presentation. I have the pleasure to introduce Professor Magdi Abdel Muqtadir. He's a professor of plastic surgery at Al-Azhar University. He's one of the leading microsurgeons in the area, and he's going to share with us his experience about reconstruction of the lower third leg defects.
Thank you, Mr. Andri, our dear professor. Thanks for kind invitation for organizing committee, Dr. Marwan, Dr. Safwat, and Dr. Qahtani. Today I will present our experience about the lower third leg reconstruction. As we all know, this area is very hard to tackle due to proximity of the skin to the bone. It's the most liable area to trauma, also shortage of local soft tissue. We should know the blood supply of the leg. The blood supply of the leg, as we know, coming from 3 arteries. It's the anterior tibial, posterior tibial, and peroneal. Also, the lymphatic, the venous drainage is from the superficial and deep system. The blood supply in the leg running in a septum show mainly blood reaching to the skin through the septum or paraseptal perforator. So we should know very well the septums in the leg. This is the septum for posterior tibial perforator, and this is the perforator of pointer. And pointer. And this is a perforator for peroneal artery. And this is perforator, the lines of perforator, and each dot point is the one of the perforators present in this area. Also, blood supply reaching to the skin through 5 plexus, we all know. And this is the picture how the blood supply redistributed through the skin and the fascia and epiphyseal tissue. And this is the angiosome, the concept, and now there is an evolution of perforator filament. As regards the lower third, we have many options, either bipedical fasciocutaneous flaps, island propeller designed posterior tibial or anterior tibial or peroneal flaps, distally based island lateral supramalleolar flap, distally based peroneal flap, distally based island posterior tibial perforator flap, distally based sural flap, abductor hallucis, distally based soleus muscle flap, and finally distally based peroneus pelvis muscle flap. As regards this case, we have no exposure of an important structure, so we can do a skin graft easily. And this is an ulcer also can be covered by skin graft. And for such difficult case, there is an exposed tendon Achilles. But we can simply resolve this problem by bipedical fasciocutaneous flaps and skin graft to the donor site. Also, another case with exposed bleed, we can simply resolve this problem by pedicle fasciocutaneous flaps and skin graft to the donor side. As regards lateral supramalleolar flap, this is one of the famous and most constant perforator of peroneal artery. It starts about 5 centimeter above and anterior to the lateral malleolus. It's a constant artery. If you haven't a Doppler, it's a constant artery. You can palpate it with your finger. The artery, after perforation of the deep fascia, is going to give an ascending and descending branch. Ascending branch is coming up to the leg, and descending branch to the foot, and anastomosis with the sinus tertii in the foot. So you can take it as distally based or as a reversed flow. We can take very large skin pattern from the lateral aspect. This is the design of flap. Child about 5 years with exposed lower cerebellum. Flap design, and this design of perforator. In a propeller fashion. And this is a post-operative. Another child about 5 years also with exposed lower third tibia. This is a flap design, the lateral aspect. And this is a flap in a propeller fashion. Thank you, Dr. Atimi. And this is the perforator. And this is the post-operative. Another case with severe degree of contraction to the foot with contracted toes. This is the donor side for lateral supramalleolar. This is the flap design. We can take very large flap. The post-operative. Another child with exposed lower third tibia. Also flap in a propeller fashion, and this is the post-operative. Another case, exposed plate and lower third tibia. This is the post-operative. Another case also. In female, we can do it as a dipofascial flap for cosmesis, and this is the post-operative. Also, as regards medial supramalleolar flap, it's also one of the constant flaps. It's based on one of the perforator of the stereotibial artery. The most constant one is about 5 to 10 centimeter, about 8 centimeter above the medial supramalleolar, above medial malleolus. This is the design of the septal, and the perforator, each dotted red point is the one of the perforator of the stereotibial artery, about 5 to 7 centimeter between each perforator. This is the flap design. This is a case of exposed lower third fibula and exposed lateral malleolus, and this is the design of the flap. And this is the perforators of the flap, and this is the flap designed, elevated, and rotated to the defect and graft to the donor side. Another case with exposed tendo Achilles. After debridement, flap elevated, rotated to the defect and grafted to the donor side, and this is the post-operative. As regards sural fasciocutaneous flap, we all know the sural fasciocutaneous flap is one of the most famous flap for the leg, and we should know all do and know this, and we have two perforator or two pedicles for the sural. The proximal one and the distal one. The proximal one is about 7 to 8 centimeter above and posterior to the lateral malleolus, and the distal one is in the retromalleolar area behind the lateral malleolus. This is the flap design for proximal one. We can reach up to the bulboleteal crease if we take the perforator about 5 to 7 centimeter above the lateral malleolus. This is a case of unstable scar on the anterior aspect of the ankle, and we can take it in a very large, very narrow pedicle, very long and narrow pedicle to decrease the donor side morbidity. This is a post-operative. And also we can see the sural nerve. It's a photo in the center. We can reserve the sural nerve for sensation and take the flap as a fasciocutaneous flap on the median sural artery and was preserving the sural nerve, as I see in this photo. And this child also can reach it up to the big 2. Child with unstable scar in the dorsum of the foot, the post-operative. Another case with the same technique I use. Another case was very long, very narrow pedicle. Another case. Another case with exposed tendo-Achilles and necrotic in diabetic patient. And this is the post-operative. And this is a distally based, in which a perforator is found behind the lateral malleolus in the retromalleolar area. And when we design this, we should stop at the middle of the legs. The flap design, the unstable ulcer in the lower third, the flap rotated to the defect and donor side grafted. This is another boy about 15 years with this horrible defect in the lower third posterior aspect of the leg and exposed bone of the heel. For this patient, I do actually the proximally based sural flap, but unfortunately, as we all know, the sural flap is one of the most famous flap for venous problem. I faced with this problem, so I decided to take the patient to the OR and go debrided and go forward for my flap to the distally based, the same sural pedicle. In the lower pedicle, this is the lower pedicle, which is present in the retromalleolar area, and this is the post-operative. This is another patient, a adipofascial flap. As regards the peroneus pelvis muscle flap, it is one of the most stable and durable flap present in the lower third of the leg. And we can cover a very large defect with my modifications, which is splitting of this muscle to reach up to 3 times its width. It's one of the 2 muscles of the lateral aspect. It is classified as type 2 and reclassified again as type 4. It's based on the blood supply from the peroneal artery and blood supply distally coming from either anterior tibial or perforator of the peroneal artery. We can take it as a distally based on at least 2 perforator, which are present mainly from the 3 to 6 centimeter above the lateral malleolus. This is a very large defect. I can do it with splitting of this muscle. This is how I do splitting. For this muscle, I can increase the muscle up to 3 widths of the muscle because I open this, the circle like, I open this circle to increase the width of the muscle. I do splitting through outer surface, outer superficial surface of the muscle, through the blood supply of it coming from the under surface. I preserve its blood supply and preserve its artery. We can grab the video. How I do splitting. And this is the pre and post splitting. You can increase its length up to 3 times. The pre and the post, I can increase the length of coverage area up to 3 times. Many cases in the lower third, about 8 by 9 centimeter. Covered by distally based peroneus pelvis muscle flap and the graft to the muscle. The pre and post. Another case was exposed the bleed after removal of the bleed by orthopedic, and this is also splitting of the muscle. Another case was exposed in the Achilles diabetic patient. Another case, very large defect. Horrible defect, very large defect, horrible defect. Another case, pre and post. So this paper was published in the PRS and gets the best paper award in the PRS in 2016. This is also for Berenice peripheral muscle flap for foot. Another modification by me and published in the Plastic Reconstructive Journal. As regards the peroneal artery flap, we can take the peroneal artery per se as a reversed flow based on the written such heroic defect. Also, distally based soleus muscle flap. This is a post-operative for free flap for harvesting the fibula done at somewhere and ended by this catastrophic defect. The patient refused free flap. This is ideal for free flap, but the patient refused free flap because he was done free flap and go some troubles and refuse. And so I decided to solve this problem with one of the distally based flaps, soleus muscle flap. This is the post-operative. Also, free flap is the ideal solution and the last solution if the local condition is so hard, such patient with unstable scar taking all the lower third, all the leg. I decide to do free latissimus. Another patient also heroic defect with no local available flaps. So I do for this patient also free latissimus. In conclusion, improvement of anatomical knowledge has allowed development of several types of flaps. The decision required consideration of simple to the most complex local flaps based on perforative vessels are raising interest in reconstructive surgery of the leg. For the lower third, the distally based fasciocutaneous flaps, distally based peroneus peripheris, and distally based soleus muscle flap, I think is the ideal. Free flap are indicated in all zones of the leg when the size of the defect is larger than the size of the local flap to be transferred. Thank you for your attention.
Thank you very much. Well, you turned out to be both a microsurgeon and a good plastic surgeon using flaps. Now I have the pleasure to introduce one of our colleagues who is a special envoy to the Gulf, he's a graduate of Kassolani Medical School, Professor Midhat Emil Habib. He's a plastic and reconstructive surgeon at Zayed Military Hospital. He's an FRCS bearing the title, and he's going to give us his talk about flaps between fingers, different modalities. تفضل دكتور مدحت.
Thank you very much, Professor Dr. Muhammad Qadri. Thanks to the organizing committee. There are the aim of flap cover for fingers is to cover bone, cartilage, or tendon to preserve the finger length and to restore the shape and appearance of the fingers. So what is the benefit of using flap from a neighboring finger? Neighboring finger has the same texture of the other finger. It has a matching color. It is a thin and pliable flap, so we avoid the bulky distant flaps. For example, if you put the hand in the groin or in the chest, then it is a bulky flap. Also, we need only to immobilize the hand. You don't have to have immobilization of the shoulder, and we get later on frozen shoulder or stiffness of the wrist joint or of the elbow joint. So neighbor finger is very important. So the idea is to always have good relations with your neighbors, because one day you may need them. We'll go through many types of flaps between fingers. The most commonly known is the cross finger flap. then the flag flap, kite flap, rotation transposition flap, Littler's flap, reverse adipofascial flap. We'll see one or two examples of each one of these. We start with the cross finger flap. It was first mentioned by Michael Gordon in 1950, but later on it was prescribed in the way which we know by Hoskins 10 years later. So this is exposure of the bone of the terminal phalanx, flap design as we know, then flap elevation preserving the paratendon over the extensor tendon. If you preserve the neurovascular bundle as a dorsal aspect, then it is, instead of being a random flap, it is an axial flap. Flap transposition and donor site recover with a skin graft. 3 days later, then after 3 weeks, we separate the flaps, and this is the shape after 3 months. So we preserve the length of the and shape of the finger. We can use for more than one finger. For example, this case was crush injury of index and middle fingers. And the two flaps raised from each middle and ring fingers to cover index and middle, and donor site was covered with a skin graft. After 3 weeks, we separate this photo after 4 months. So the length preserved and the bone covered. Another type of flaps which we can use between fingers is the flag flap. This patient had fractured proximal phalanx of the index finger with a cut of the flexor digitorum profundus tendon. Tendon repair done, but the tendon is exposed. So flag flap was raised from the middle finger, which is a neighbor finger, and flap raised and used to cover the flexor digitorum profundus tendon of the index finger. Another type is a kite flap. As we know, it is used usually for the thumb, and we can use it as pedicelled flap with undermining of the skin between the thumb and the index finger, but there is possibility of partial ischemia of the flap. So the safest way to use is to use a pedicle of skin over it. So this is another case with tissue loss of the thumb with exposure of the bone. So kite flap plan raised with an island of skin, of course utilizing the second dorsal metacarpal artery, and the liga clips applied on the branches of the artery, flap transposition, and covering the thumb pulp. First type we discuss is the rotation transposition flap. If you have a raw area at the tip of the thumb, then you need to cover this area. You can use, actually, unfortunately, this pointer is not showing here, but we can transpose the flap from the first rib space between the index and the thumb to cover a defect made by another flap, which is a rotation flap distally of the thumb as the volar aspect. Amputation of the tip of the thumb. If we put the graft here, then we have no sensation at the tip of the thumb, and also we have exposure of the bone. So this is the design of the flap. One flap will be rotated up, which is at the pulp of the thumb. The other flap is from the first rib space between the thumb and the index to cover the defect resulting from the first flap. So this is the flap which is we transposed. So this is flap already rotated up, preserving the neurovascular bundle. And this flap is raised. This is a flap raised from the first rib space to cover the triangular defect created by the first flap. And we close the donor site of the second flap. So advancement is about 2.5 centimeters. And now the defect of the thumb has been closed. This is about 3 months later. These are the two flaps together. The lateral flap is well known. It is a neurovascular island flap, and we take it from the ulnar side of the ring or the middle finger to cover defects of the thumb. This patient had amputation of the thumb. There is loss of part of the terminal phalanx, loss of part of the interphalangeal joint, and the loss of head of the proximal phalanx. So lateral flap raised based on the ulnar neurovascular bundle of the ring finger, measurement taken, undermining will be done, then a catheter inserted and sutured to the flap and delivered to cover the defect. And this is the flap. After covering the defect, this area at the proximal to the flap we can cover with a split thickness skin graft. We took full thickness graft for the other fingers, and the split thickness skin graft applied as a pedicle to prevent constriction of the blood supply. And this is 3 days later. And this is after sutures removal. Another patient was exposure of the flexor pollicis longus tendon, lateral flap design, flap raised based on the ulnar neurovascular bundle, measurement taken, and then flap delivery to the defect. The flap covers the flexor pollicis longus tendon. The sides we can cover with split thickness skin graft. And this is after sutures removal. Combined Moberg flap with reverse artificial flap. This is the last case we'll discuss. So this patient had the degloving injury of the thumb with exposure of the terminal phalanx and even extensor pollicis longus exposed. So Moberg flap was done from the volar aspect of the thumb, including VY advancement at the base. So it is not classical Moberg, it is Moberg with VY advancement to cover the defect. Volary, then at the dorsal aspect, reverse adipofascial cross finger flap. We raised the skin, then we took the adipofascial layer, we preserved the paratenon of the extensor tendon of the index finger, and this flap was used to cover the rest of the raw area. So we have combination of two flaps, Moberg and reverse adipofascial, and this reverse adipofascial was covered with a split thickness skin graft. After 3 weeks, we divide the flaps. Last case is a triple reverse adipofascial flaps. We had this patient blast injury in Yemen War with fracture proximal phalanx of the index finger and exposure of the bones of the proximal phalanx, middle phalanx of index finger, and proximal interphalangeal joint of the middle finger. This is the raw area. So 3 flaps were designed at the same time, reverse adipofascial flaps, one from the proximal phalanx of the middle finger to cover the proximal phalanx of the index, and from middle phalanx of middle to cover middle phalanx of index, and from middle phalanx of ring to cover PIP joint of the middle finger. It's the first flap raised, and you can see even there are holes in the flap from the blast injury. The 3 flaps raised at the same time, and transposition done to cover the exposure of bones and joint, and the split thickness skin graft applied on the flaps. We keep them attached for 3 weeks. After 3 weeks, we divide the flaps. In conclusion, finger injuries are the most common injuries to the upper extremity. Successful repair requires knowledge of the anatomy and physiology, the mechanism and extent of injury, the techniques of reconstruction, and sound surgical judgment. Using flaps between fingers provides near adjacent tissues of similar texture and avoids the drawbacks of distant flaps. Thank you.
Thank you, Dr. Magdi, sharing with us those very complicated injuries. I'm going to present my next presentation. I'm a graduate of Qasr Al Aini Medical School. I've had the pleasure and the honor to work for this faculty. Our faculty is the oldest one in the area. It's been established since 190 years. And as faculty members, we supervise a lot of research and of theses for young surgeons who are becoming very famous in the field nowadays. So let me give you my talk. Bismillah ar-Rahman ar-Rahim. Our talk today, I'm an emeritus professor of plastic surgery, Faculty of Medicine, Cairo University. We're going to speak about complicated cases of heel defects. There are challenging problems. A lot of patients are elderly, diabetic, debilitated, and they suffer from different changes in their physiology and neurophysiology. A lot of flaps have been designed for heel reconstruction. In order to achieve a better selection, a thorough understanding of the anatomy is mandatory. We had to use not only Doppler, but the Doppler flowmetry. It helped at localization of the site of the perforators as well as the feeding vessel of different flaps. We should understand that in those cases, we suffer circulatory disturbances at two levels, macro angiopathy and micro angiopathy. Monitoring of the flaps postoperatively for early detection of disturbance of the flaps microcirculation. This is mandatory for the possibility of re-establishing an adequate metabolic state of the flap. Both targets can be achieved by recent non-invasive vascular studies. The flow Doppler scanning is for the macrocirculation. The microcirculation is assessed by the laser Doppler fluximetry and the transcutaneous oxygen saturation. This is the equipment we have been using. Those are old equipment, of course, when this study was carried at the laboratory vascular lab, which belongs to the medical department. The idea here is that there is a transmitter of waves. The waves are going to hit the blood vessels, which are present in the red blood corpuscles, and then they are transmitted to a receiver. The wavelength is different. The only problem with this equipment is that it should be standardized. You cannot compare different equipment together, so you have to use the same equipment for all your studies, and the probes and the equipment parameters must be equal, and it should be calibrated every now and then using a colloidal solution. There are certain factors that may falsify the results, such as the temperature of the subject, the systemic blood pressure, oxygen, carbon dioxide saturation, and pH, the status, food and medicine, the stress, the propagation, the occlusion, the posture. All these should be taken into consideration. Concerning the transcutaneous oxygen monitoring, this has been used since the late 1970s. It's in need for non-invasive continuous monitoring, and it initially used for neonates. Nowadays, this is an electrode which is used, and it's applied for wound care, hyperbaric medicine, vascular surgery, orthopedic, adult ICU, and sleep disorders. A new surgical application of both LDPM and TCPO2 in the preoperative flap selection and postoperative flap monitoring to anticipate venous or arterial occlusion. This is a study which was carried on 30 patients. Their age ranged between 15 and 50 years, with a mean of 38. The different parts of the exact site of the heel defect are shown in this diagram, and the cause of defect in the great majority of cases is diabetic. It might be neuropathic, and it might be traumatic. The flaps and other modalities which are selected, the great majority is the posterolateral malleolar, and my friend Magdi has shown the basic principle of most of these flaps: the reverse sural artery flap, the medial plantar flap, the free radial forearm flap, the cross-leg posterior flap in one case, and a split thickness graft has always a place, even as a temporary biological dressing, and primary closure, of course, if there is a residual defect at the end. Results: complete survival of 23 flaps, necrosis of distal part of one flap, later split thickness graft was used, total flap loss in one case of free flap. In all cases, the first post-operative week, the oxygen saturation is going to decrease more than the decrease in the perfusion. And this is due to a progressive, and then this is followed by progressive equalization between the second and the fourth week. And this was explained by a temporary venous congestion due to the arc rotation of the flap. We went a little bit deeper and we evaluated each flap separately concerning the two parameters which were used. And for both microcirculation and the oxygen consumption. As we can see, we are comparing the three flaps, and this is how we're going to conclude at the end which flap is the safest to be used. It comes in the first place, second place, and then the third place. And as you can see, there is the drop in the first week, and then it stabilizes, and then it resumes its normal activity. This is for posterolateral malleolar flaps. I don't want you to go into details, but this was the idea of carrying the mean value, the statistical evaluation, and things like that. So can we draw our conclusion based on evidence and things like that. So the oxygen saturation change over the 4 weeks post-operatively, it drops, and then it raises a little bit, and then it stabilizes. Individual cases, result of reconstructive modalities. A reconstruction by the posterolateral malleolar flap. This is actually an old flap which has been described by Masculet in the mid-80s, but it hasn't been used at the time very frequently. We can use it either as a pedicle flap or it can be used as an island flap. And by the way, in most of these flaps, you don't have to skeletonize. You don't have to expose the feeding vessel because actually skeletonization may induce a form of spasm of these vessels. A dog ear is present. The dog ear, if it's left for 3 weeks, it diminishes, and then it can be excised under local anesthesia or under spinal or epidural anesthesia. This is the neuropathic trophic ulcer, flap in situ. Split thickness graft for the donor site. Traumatic, flap raised, flap in situ, and then follow-up after a few weeks. I'm going to show you a case. This is a good result. In some cases, you can have a disruption. The disruption might be due to infection, and yet the follow-up shows you that the vascularization is good. So all what you have to do is to detach the sutures and then to put the flap back into position, and then you apply secondary sutures. So total healing after control of infection and resuturing of the flap. The reverse sural artery flap, I think it's, well, the reverse, it carries certain risk. It's based on the artery, which is the sural artery. Even if you lose a part of the flap, the fascia is still there, and even if you put a split thickness graft, the results are very acceptable. This is a defect. This is the donor site. This is the flap after it has been debulked, and the final result. Should be patient, traumatic ulcer healed, delayed sural artery, flap rotate to the defect, heel ulcer covered with bulky flap, result after debulking. The medial plantar artery should be kept. It shouldn't be used since the start because you're inducing another injury to the sole of the foot, which is a very precious part. But it's a wonderful flap because it's the same constitution of the skin of this area. And this is a flap after it has totally healed. The defect of the donor site is trivial. A radial forearm flap, microsurgery, is not available in all centers. You should not particularly have the experience to do it. So you should always resort to a microvascular surgeon to help you carrying such a result. So heel defects are difficult reconstructive problems. In paraplegics, you can use whatever flaps. Elderly, on the contrary, they provide a poor terrain on which to plan these flaps. Absence of peripheral pulses, antecedent coronary, peripheral vascular thrombosis constitute some of the hazards or local flap survival. If skin cover using a flap is decided, you should opt in the first place, guided by the LDF and transcutaneous oxygen saturation for the preoperative selection, but this is not the most important method for selecting the technique. A lot of wound dehiscence were due to infection with total survival of the flaps after control of infection. If ischemic changes occur, this indicates repositioning of the flap and saving of as much as possible. If we are proposing a plan, we should have figures. When should we stop? When should we reposition the flap? When should we proceed? So we observe that preoperative flap selection using these techniques is not significant, but we can rely on postoperative flap monitoring, as posterolateral malleolar flap is a very versatile flap, even with potentially ischemic limbs, as shown in the postoperative monitoring of such flaps. So this flap can be used, it's highly recommended whenever possible. If this is not possible, due to whatever reason it has been attempted or a trauma is affecting this area, medial plantar artery flap and reverse Schurer flap can come next. They are both reliable flap. In few selected cases, the use of distant flaps like cross-leg flap. In my whole career of 52 years, I think I've done 1 or 2 cases. I'm not very much for this technique in the presence of the microvascular free flap transfer. So our recommendations are, after meticulous analysis of the data, the posterolateral malleolar flap is the most reliable flap for heel coverage, even in patients with distal arterial insufficiency. It does not need fine vascular dissection, and it has a wide arc of rotation. The most accurate predictor for flap survival is estimation of transcutaneous oxygen and the percent of change in the early postoperative period of each flap. If you have a drop in oxygen saturation more than 90%, stop. In the first week, this is an indicator of a flap failure. A drop of oxygen saturation between 80 and 90 is borderline, and in turn, it depends on the type of the flap for tolerating these changes. It might be an indication for repositioning of the flap, using it as a delay and continuing your procedure. The dependence on blood flow perfusion of the flap gives a false impression about the survival. The underlying disease affected very much. This slide is going to show you that the behavior of the duplex flowmetry and the oxygen consumption differs from one flap to the other, the safest being on the flap on the left-hand side, upper hand, and they are going to survive at the end, but you should have a good knowledge in the follow-up. In conclusion, the non-invasive vascular studies showed some value in preoperative flap selection. It was, however, of great value in postoperative flap monitoring. Well, it's not working, not anymore. Thank you very much. A very good friend who couldn't come, Dr. Yahya Zakaria, is a professor of plastic surgery at Zagazig University. This is a governorate in the Delta Valley of the Nile. He's going to give us his talk about the coverage of wounds around the knee by flaps, a diversity of options. تفضل يا دكتور يحيى.
Muhammad Qadri. Oh, actually, it's a great honor for me to describe me as your friend. Actually, I'm your student, and it gives me an honor to be your student. I would like, hello? Hello?
يحيى اتفضل. You should share
أيوة يا فندم أنا
بس السلايدز ما ظهرتش.
I'm sharing.
احنا سامعينك وشايفينك.
طب
You can put the presentation and it starts sharing it with us.
yes.
What should you do?
تمام كده. I'm sharing بيه.
It's not appearing yet.
I'm doing screen sharing.
Guide him بقى.
كده باين يا بيه؟
لا كده احنا شايفين وجهك الصبوح يعني. تحت في شيرنج.
يس، ما انا عملت كده. بيقول لي allow Zoom to share your screen، قلت له allow.
Which one? The green one?
The green one.
The
yes.
green one.
Yes, I did this.
Click on the green one. Huh?
I did.
Click again. The arrow is not coming on the icon, the green icon.
يقول لي open system preference.
السهم يا يحيى وتعالى على الايكون. ايوه هتبتدي بقى. لسه بيمشي.
حضرتك
لسه
شايفني كده؟
معلش ريلاكس.
اوكي.
كان
كده باين
somebody.
ليه ولا مفيش حاجه باينه عندك؟
ايوه في الايكون الاخضر يا يحيى تحت الصوره
دوست
بتاعتك.
عليه يا بيبي.
You want to change the host. دوس على السهم الاخضر.
دوست عليه يا بيبي. بيقول لي بيفتح لي حاجه اسمها privacy في السكيورتي اند برايفسي.
لا
بيقول لي
لازم
allow the app to.
تدوس على شيرنج.
دوست عليها بيه.
Please help us. Which icon? The green one in the middle. Click on the green icon. The green icon.
دوست عليه.
يا عم انت التكنولوجيا كلها.
تفتح ان شاء الله يا بيه. هتفتح.
باين على الموبايل عندك؟
عمال بيطلع. باين على الموبايل؟ لا، على اللابتوب. كده باينت حضرتك؟
لا كده احنا شايفينك انت. اطلع وادخل تاني. اطلع وادخل تاني.
اوكي طيب حاضر. ايوه يس. هلو. I did this. I pressed on sharing. I pressed on the green button.
دوس على اوت. اطلع بره. اطلع.
في حد بيكلمني يا بيه من الاوديو فيجوال. الو.
You are in contact with him?
Yes.
He's calling you. Okay,
Yes.
you follow the steps with him.
Yes, sir. أيوة.
الراجل محضر القعده وحاطط تابلو وعامل 100 فل و10 يعني هيعمل. Press escape or double click. You are speaking in English with him, or well, I hope you reach.
Bear with us. We will just get this sorted.
Okay. Type. We're going to open discussion until we reach something. Are there any questions from the floor for the first presenter, Dr. Tariq Al-Menoufi? I've done such fish cutaneous flap in the 90s, a lot of them actually, and I would advise not to skeletonize. You can do a blunt dissection unless you want to use it as an island flap. And I've seen that you're not using it always as an island flap. Avoid too much exposure. Too much exposure may result in some spasm of the vessel. It's a wonderful flap. بجد يعني it's really a wonder and very safe flap, and it hardly ever suffers from any congestion. Any other question?
Thank you.
طيب, second speaker, الدكتور مجدي عبد المقتدر. اتفضل.
Thank you, Magdi, for your effort. And we have a sentence كده for Magdi in Egypt, the best flapist. Thank you, Magdi. But I want to discuss with you, what about the dog ear after your rotation of this flap? What can you do in it?
You mean Shural? You mean Shural. As Mr. Kadri described, the dog ear will be resolved after about 3 weeks. But even حتى if it's not resolved, we can under local anesthesia and excise it. Yeah, under local anesthesia, but actually it's resolved after about 3 weeks.
When the edema subsides, the dog ear diminishes greatly. If you wait for a month, you can do it even under local anesthesia. Yes.
Yeah.
Yes, yes. دكتور مدحت, any question? أنا أهنئك, أنت بتشتغل في الخطوط الأمامية, or working on front line, and apparently where you work in a military hospital, you have a lot of these injuries. We don't have the opportunity to see so much mutilated hands in a private practice. Of course, you are in very good command of a lot of the flaps. Some of them I know about them. Some others I hadn't, I know about them, but I hadn't a chance to use it. So what are your priorities selecting the flap?
It depends on the type of injury and on the site of the injury also. For example, if we have volar tissue loss, then we think of cross finger flap. If we have dorsal tissue loss, we think of reverse atopofacial. And it depends on the surrounding fingers.
Yes.
If they are well viable and we have a good tissue for flap cover, then we use these fingers. But of course, if the fingers are badly mutilated, then we may have to use distant flap or other way.
Okay, I have a question. You are using a lot of neurovascularized flap with a very long pedicle, transmitting from the little finger to whatever. A big arc of rotation, bending and things like that. They never suffer compression or congestion or loss of the flap?
Yeah, I showed one case, kite flap with pedicle without island, without overlying skin. So this case, I showed the photo, it has distal ischemia. But the other cases of kite flap, which we have overlying skin, we preserve the skin, and we don't try to separate the vessel from the overlying skin. In such cases, we had no issue. But I had one case also of flap failure by accidental injury of the vessel. I had one case, the use of kite flap. But other cases, we have 100% viability of the flap.
Any other question? Any question for my presentation? And I want to raise a recommendation. no repair or reconstructive surgery in any plastic surgery department, it should have its vascular equipment. It should have somebody who is doing the job. At our faculty, we're depending on a vascular lab belonging to the internal medicine department. We couldn't manage to have an in the location site, but nowadays you cannot depend only on the Doppler. You should depend on more sophisticated equipment. That is Hope, who is Dr. Yahya Zakaria.
His lecture here. We'll shift his lecture only here.
Okay,
So we'll give him a chance once his machine.
We're not replacing it.
No, it's okay.
Okay.
We'll
Well,
manage.
since there are some technical problems with the presentation of Dr. Yahya Zakaria, we come to the end of this session. I thank the audience, I thank the speakers, and I call this session closed. Thank you very much.
Ladies and gentlemen, we now conclude session 2. Thank you so much, Dr. Mohammad Qadri, for your time. I have an important announcement to make. May I please request all the speakers to go ahead on the registration counter to collect your certificates. Yeah, I repeat, may I request all the speakers to head ahead to the registration counter to collect your respective certificates. And now we have our coffee o'clock. Kindly go ahead with your coffee. I shall see you at 11 o'clock. Thank you.
Hello, do you hear me? Hello?
Check, check, check. Good morning, everyone. I'm truly delighted to welcome you all once again after the coffee break. May I please have the honors of calling upon Dr. Taisir Abdulal and address the gathering, sir.
صباح الخير. Good morning, everyone. Good morning, Professor Dr. Marwan. I would like to thank you for my invitation in this very nice and valuable meeting. Thank you, Dr. Marwan. Thank Dr. Kahtani. And I know that Dr. Safwat Al-Husseini is with us on the screen. So thank you, Dr. Safwat, for your invitation. Thanks to Dr. Atif Imam, and thanks for Mr. Fadi and for all the organizing committee. Firstly, I would like to introduce myself. So this is my talk. Actually, I am not a surgeon, and I am not lucky enough to be a surgeon. I am a rheumatology and a clinical immunologist. I was born in Saudi Arabia since 14 years, so I have many friends in the Gulf area. So this is my photo since more than 40 years. My talk is a very short talk about the highlighting about is there is a connection or interaction between the ulcers or surgical ulcers and the autoimmune disease, because of in my clinic and in my patients, many of them came to the clinic with an autoimmune disease which related diagnosis. So the autoimmune vasculitic etiologies should be considered in patients with chronic wounds. Which wounds don't respond to appropriate vascular intervention and standard wound care. In US, these wounds approximately reaching 6 million, 25 billions per year, and about 6.5 million people in the US with a percentage of 1% that costing that 25 billions per year. These wounds significantly impact mortality and cause, of course, considerable pain, affecting patient-reported psychological well-being and the quality of life. I'm going to show some pictures about the autoimmune ulcers or autoimmune vascular ulcers that may need surgical intervention. This is like ulcers associated with rheumatoid arthritis. From 5 to 25 years of diagnosed rheumatoid arthritis, about 4 to 26% having these ulcers. 6% of the ulcers lead to amputations, and ulcers were associated with increased mortality adjusted for age. Ulcers, of course, increasing with erosive disease and the more aggressive autoimmune disease, that's 63% of the RA seropositivity. This is like ulcers associated with systemic lupus erythematosus, which about 2.6% had underlying SLE compared to the reported prevalence of less than 1% in the general population. This is scleroderma and mixed connective tissue disease associated ulcers, about 4% of the patient. This is like ulcers due to the ANCA-associated vasculitis, which is anti-neutrophil cytoplasmic antibody-associated vasculitis. The anti-neutrophil cytoplasmic associated vasculitis includes the granulomatosis with polyangiitis, which is formerly known as Wegener's granulomatosis, microscopic polyangiitis, and Churg-Strauss disease. Digital ulcers or gangrenes due to thromboangiitis obliterans, which is the Berger's disease, which is a famous disease in the vascular surgery. About 6% in the Western Europe and 63% in the Indian, and to be should considered in any patient with critical limb ischemia under the age of 50. Big ulcers due to pyoderma gangrenosa. About the COVID, post-infectious or post-COVID vaccination, there is a reported vasculitis, which is cutaneous vasculitis. And this issue for research and for more study. And of course, one of our colleagues will present something about the wound care before and after COVID-19. This is a differential diagnosis of vasculitic wounds, either infection associated with vasculitic and chronic wounds, erythema nodosum, sickle cell associated leg ulcer, and of course, plaquenil or hydroxyurea associated leg ulcer. Occlusive disease resulting in ulcers, which is the cryoglobulinemia and cholesterol emboli and so on. Prothrombotic wounds like antiphospholipid syndrome and genetic prothrombotic state. What's the rule of biopsy? I highlight on this. The rule of biopsy in the rheumatoid arthritis, which is reported, is to exclude the infection and not diagnose the vasculitic lesion or something like this. We take the biopsy if needed to exclude the secondary infection that delay the wound healing. The treatment strategy in the autoimmune disease, starting from steroid, vasodilators, disease-modifying anti-rheumatic drugs like methotrexate or sulfasalazine, etc., colchicine and dapsone, and the biological treatment, which is called biological weapons, plasmapheresis, and intravenous immunoglobulin. Which of these, or combination of these, this is according to the case or according to the disease severity of the patient. In some cases, we do 4 or 5 combinations of these. So my recommendation is to consult a rheumatologist if there is a resistant wound that lasting more than 3 months, not affecting by the ordinary surgical treatment. So consult the rheumatologist, and this is my message, that's all. Thank you. Now we are going to the next presentation with Dr. Wael Sakr, which is about wound dehiscence in aesthetic surgery, high risk. This is a Zoom presentation. Please, Dr. Wael. Dr. Wael, you hear us?
Yes, I hear you. Can you hear me?
Yes. Please start, Dr. Wael. We saw your presentation and we hear us. We hear you.
Hello, good morning. Good morning, everyone. Thank you for the organizing committee. Unluckily, I was not lucky to share this nice gathering in a nice country. Thank you very much. I hope we meet in next meeting, inshallah. Today, also I thank Dr. Safwat and the organizing committee. Mr. Chairman, our talk today is about wound dehiscence in aesthetic surgery. So many times we do aesthetic surgery and the patient is concerned with the scar. So it's an unlucky event to have this dehisced wound. This is Al-Azhar Mosque, one of the ancient universities in the world. And this is the ancient Egyptian surgery. Definition. If an incision separates following surgery, the wound considered dehisced. This means that it has split along a natural line. The split can happen in just the skin layers, or the entire wound can open and back up. Wound dehiscence is the separation of the edges of the surgical wound. It may be just the surface layer or the whole wound. It may become a serious problem. Dehiscence is a surgical complication where the edges of a wound no longer meet. It's also known wound separation. A healthy healing wound will have edges that meet neatly and are held closely together by sutures, staples, or another method of closure. There is another definition for the evisceration, which internal organs come out through the incision. Wound healing stages, as we all know, and I think so many of the speakers told you about, is the 4 main stages of hemostasis, inflammation, proliferation, and remodeling. These are the 4 stages. And this is the distinguished second space of clotting by the aid of platelets and fibrin inflammation, which involves cleaning and healing lately in the wound. How long does it take for a normal wound to heal? An open wound may take longer to heal. Open wound, longer time to heal. A large deep cut wound will heal faster because it is very thin. According to John Hopkins, after about 3 months, surgery cuts normally take maybe 6 to 8 weeks. Wounds need moisture to heal. Anatomical considerations, these are the layers of the skin with the blood supply, and these are the layers of some of our operations, either in the neck or in the abdomen or breast. Types of surgery which are more prone to wound dehiscence. Open surgeries are more liable to dehiscence than the minimally invasive. Also, the wounds of emergencies operation and the potentially infected wound. Those are the types which are more prone for dehiscence. Dehiscence may occur early or late. Early in the first 3 days, which may be ischemic. A wound is at the greater risk of dehiscence in the first 2 weeks after surgery, when the wound is still fresh and fragile due to tension or infection. Lately is deep dehiscence. Because of all the layers, it will present very late. Why wounds reopen? What are the risk factors? These are the risk factors which increase the incidence of having a dehiscence after plastic surgery, and mainly aesthetic surgery. Obesity, malnutrition, smoking because of vasoconstriction, peripheral vascular disease, because the wounds needs good blood supply to heal, respiratory diseases, cardiovascular diseases, anemia, cancer and chemotherapy and radiotherapy, age-related, sex-related, and steroid injection. What are the extrinsic causes affecting the outcome? The surgical experience of making the operation and closing the wounds. The operation theater and the antiseptic technique. This is the infection, emergency surgery, and re-exploration. This is the whole. Straining from coughing and vomiting post-operatively or sneezing may open the wound, which is under tension. Other risk factors, having a scar in a previous irradiated site. And we will see an example for this. If you're going to do an operation in a previously irradiated woman. Not following instructions for care after surgery. The patient may exercise too much or lifting heavy objects. Increasing pressure within inside due to constipation, coughing, inflammation, straining, and vomiting. Long-term use of steroids. Other medical conditions as diabetes, kidney disease, chemotherapy, and radiotherapy. The etiology of wound dehiscence may be infection, injury to the wound, trauma to the wound post-operatively, early stitch removal. If you are used to remove the stitches after 7 to 10 days and you remove the stitches on the 4th or 5th day, weak tissues in the wound area, or incorrect suture technique. So we divide it into the causes of these into pressure from within, pressure from outside, tension, infection, and vascular compromise of the wound edges. This is our new Alamein city in North Coast, Egypt. Pressure from outside. If you use a garment or pressure garment, pressure bandage, this may cause compromise of the skin blood supply. If it was too tight. Pressure from within. If you're putting a breast implant, which is bigger than the size of the pocket, it will open the wound like this. Or in reduction mammoplasty, if there is inequality between the skin covering and the deeper tissues. Proper marking is a good part of the operations in aesthetic surgery. So if we are not going to do a proper marking of the skin excised and removed, you will get this complication. Tension. This is a reduction mammoplasty. If you are closing the wound under tension, it may open again like this. Bad technique, inexperienced surgeon, wrong marking preoperatively. infection. This starts from the deeper part. The infection starts from the deeper part of the wound by hematoma or seroma. This leads to pus formation underneath, necrosis of the deep tissues, and dehiscence of the wound lately, and the wound will open by the whole length. Vascular compromise, thinning of breast reduction flap, arterial affection of the areola in breast reduction, venous congestion of the areola, wider dissection in tummy tuck may cause gangrene of the flaps. Presentation of wound dehiscence may be small or big event, either broken 1 or 2 stitches, sudden pulling pain, the patient will experience it, bleeding from the wound, swelling of the wound if there is infection, redness, fever if there is pus, visibly open wound lately if it is already open. Diagnosis, the surgeon will examine the wound if there are signs of infection, and the following may be done. Sample of fluids and tested for bacteriological examination, blood test to see the infection. Further tests may be needed if the wound is deep or not healing. Some investigations may be done, X-ray, ultrasound, or CT scans to see if there is pocket underneath the wound. How can we prevent? The best way to prevent dehiscence after operation is to follow the doctor's instruction and surgical recovery. Best practices, some of these are: avoid lifting heavy objects more than 10 pounds, especially in abdominal operations. Prevention also may be extremely cautious in the first 2 weeks. We should work to avoid DVT or pneumonia, but in most cases you shouldn't push yourself to walk again. After 2 to 4 weeks, start slightly more rigorous physical exercise at your own pace to the patient. This is the words we tell the patient. If you start to feel pressure, consider taking 1 to 2 days rest and taking 2-day rest and try again in another time. Management. Wound dehiscence that's not treated can become a life-threatening condition. Treatment of wound dehiscence either medical in the start, painkiller if there is pain, dressings, debridement, and lately coverage if there is wound defect. This is an example. These are of breast reduction, ischemic edges of the skin after. It's a tummy tuck, ischemic edges, and it opened. But fortunately, it was very superficial and the deep layers. And this patient healed by secondary intention. Another abdominoplasty or tummy tuck, we have infection, loss of fat, fat necrosis, and opening of the central part of the wound. And the healing by secondary intention. This is an ischemic edges, as you see from the color. This is umbilical stump after abdominoplasty, showing separation due to the deep infection, and you can see the Prolene stitches. Also, this is an umbilical gangrene, vascular suffer. This is if you are not going during surgery to preserve the umbilical perforators. The umbilical, when you are doing an umbilical transposition, this may be the result. So be careful when you dissect around the umbilicus. This is a reduction mammoplasty in an inverted T manner, and the vertical limb was closed under tension. As I told you, it may be inequality between the skin you are closing, and if you are not going to, in this patient, if you remove more of the parenchyma and reduce more the size of the breast, the skin would have be sufficient to close it at ease, or to leave more skin to. This is an equation, I mean. This is loss of areola. The nipple is on the right side of the photo. This is due to vascular impairment of the areola in breast reduction, after reduction mammoplasty, and it's treated by dressing and grafting, and later on some nipple operation. This is the loss of the areola, dehiscence of the circumareolar wound. This is a superficial skin suffer in the longitudinal limb and tension at the T junction of the T part of the breast reduction. This is also the areola is intact. This means that there is no vascular. The vascular pedicle of the areola of this supromedial pedicle was healthy, but the tension opened the circumareolar and vertical incision. Combined infection and ischemia of the skin edges. This is a brachioplasty showing T-junction also suffer between the vertical and horizontal limb in the axilla. This is total gangrene of the areola. It's a vascular compromise. As I told you, this is a TRAM, transverse rectus abdominis myocutaneous flap for reconstruction of a cancer breast patient. This skin was irradiated. That's why it suffered. As you see, the skin monitor of the flap is healthy and is living, but the mastectomy flap, which was irradiated before, is suffering a little. This will heal by dressing and secondary intention. This is an important issue, which is laser liposuction burn, which nowadays we can see it in power or machine-assisted liposuction, either using laser or ultrasound. It should be done with very cautious technique, so as not the heat will not spread to the superficial skin. The management, either I told you conservative management in the most of the cases, medical treatments and antibiotics, dressings. We do dressings either by enzymatic debridement, creams, healing creams or spray, duoderm patch, or negative pressure wound therapy if the wound, if the gapped wound is infected or wide. Negative pressure or VAC therapy. This treatment, the conservative treatment, either lead to. This will be the result by the conservative treatment, I mean. Healing by secondary intention. Then we do scar revision or granulation tissue formation, then grafting if it is wide area, or if it is small and cleaning, and then secondary sutures. These are the surgical treatment, secondary sutures, skin graft, or scar revision for any dehisced wound. What are the precautions? To sum up, good medical control of any pre-existing condition, diabetes, steroid, malignancy, hypertension, bleeding tendency, proper pre-operative planning and marking to ensure enough skin, ensure bloody viable flap during dissection and closure. Good blood supply to the distal end of the flaps will mandate closure. Strict antiseptic techniques to minimize infection, minimize handling and air exposure of implants and expanders, good coaptation of the wound edge, choice of proper size garment, drainage of any dissected space to prevent hematoma formation and later on infection. Stitches should be removed in the proper time, prevent and minimize post-operative straining. Be very careful when operating on previously irradiated skin. Thank you very much.
Thank you, Professor Dr. Wael, for this valuable talk. Our next presenter, Professor Dr. Muhammad Al-Nasser. He is going to talk about wound complication following post-bariatric body contouring surgery. Please, Dr. Muhammad.
Bismillah ar-Rahman ar-Rahim. Thank you very much for giving me this opportunity to present today. And I would like to thank Dr. Wael Saqr for making my life easier by his earlier presentation. I'll be talking about the wound complication post-body contouring after massive weight loss. Actually, I'll be sharing with you my experience in the last 13 years. It's a modification of 3 techniques or 3 main schools. The French school by Leloir, Francois Pascal, and the American school by Dr. Ali, and the Latin American school Brazilian by Dr. Roxo. The message I'm trying to deliver here is not just a simple procedure. It's a complex procedure. It's a lengthy procedure. You have to develop your skills as time goes by. I think the most important thing for you is to be fast in this procedure, in the good term of being fast, to limit your operative procedure to 4 hours, 4.5 maximum, in order to decrease the surgical site infection, wound dehiscence, etc. You have to limit your mobilization and turning during the operation if you're doing body tilt. So it's just two position. Either you start with prone, then you shift to supine. You have to have proper selection of patients. So patients, they have to reach their proper PMI with a BMI less than 30, and you have to wait at least 1 year after the bariatric surgery, and they have to maintain their weight for 3 months, and they have to be psychologically stable. This is very important take-home message. So why body contouring surgery? You deserve to feel healthy, you deserve to look good, and you deserve to feel good about your weight loss. Patients usually suffering loose, hanging skin, rashes, difficulty moving, and clothes doesn't fit properly. And the result depends on the integrity of the musculoskeletal layer, distribution of fat, the location of scars, incisional hernia, and skin tone and quality. Most common area is the abdomen, usually the abdominoplasty combined with a belt, or plus or minus gluteal fat augmentation, or liberal use of implant. Brachioplasty, extension of the brachioplasty in the lateral thorax, breast lift, breast augmentation, and thigh lift. These are the most common procedures. So you have to have a stable weight, non-smoker patient, optimal health, and good nutrition. You have to optimize these patients before the surgery. And it's not just the first consultation on which you will decide to go for surgery. You have to have 2 or 3 preoperative visits in order to determine the proper procedure for such patients. So the contraindications, scars above the umbilicus, this is future pregnancy. You have to have patient to abstain from pregnancy for at least 1 year. Gross obesity, BMI more than 35. Some patient between 30 and 35, I will do some procedure for them, but usually I will go with BMI less than 30. Smoking, diabetes, poor general medical condition, thromboembolic disease, and unrealistic expectation. Risk, serious complications, heart and lung problems from anesthesia. So that's what I implied earlier. You have to limit your operative procedure for 4 hours, and you have to work with teams. I usually work with an assistant and 2 scrub nurse, minimize any shifting procedure during or turning during the procedure. I use high tumescent, high adrenaline in the tumescent. I use 1 milligram in the 500. And I wait for 20 minutes. Some people will wonder why you have to wait. This is, you will give the time for the adrenaline to work, and it make your life easy when you're doing the liposuction. I practice safe liposuction. I'm not sure if you are aware of it, but I guess most plastic surgeons here are aware of safe liposuction, which imply the separation of fat, the aspiration, and the fat equalization. So as I mentioned earlier, you start with the consultation, and patient has to be cleared if they have other medical condition, diabetes, hypertension, etc. So usually patient present like this, deflated body parts, whether it's the abdomen, the back, the thighs, hanging of the mons or paniculus, thigh laxity with different types of laxity. It can be asymmetric as well. This is a study published in JAMA in 2001 about the prevalence of obesity and diabetes. And it shows that a weight gain of 11 to 18 pounds increased the person risk of developing type 2 diabetes. That's of the individual have not gained weight compared to patients not gaining weight. And more than 80% with diabetes are overweight or diabetic or obese. Incidence of heart disease are increased in persons who are overweight, and high blood pressure is twice as common as non-obese patients. So it's a changing quality of life. It's not just it's a cosmetic procedure. It's more of a reconstructive procedure. So they increase the safety and effectiveness of bariatric CAG, give plastic surgeon additional opportunities to refine the body contouring, and the positive physical improvement that often accompany the weight loss as well as increase in self-esteem can equate to improved quality of life of these patients. This is a study published in PRS in 2008 by Mohammadi, which shows the potential impact of nutritional deficiency of bariatric patient on body contouring surgery, and shows mostly that almost 25% of weight loss patients are at risk of developing protein calorie malnutrition, and that's why they are more prone to having those wound complication, wound dehiscence. They are sometimes, some of them are immunocompromised. So protein deficiency impairs wound healing because of protein is needed for fibroblast proliferation, angiogenesis, collagen production, and edema adversely affect the perfusion of healing of tissues. So they can present with plethora of vitamin deficiency, folate deficiency, vitamin B6, vitamin B12. Incidence of vitamin C is almost like 1/3 in both the bypass procedure and vitamin A deficiency. You have to actually, if you're a plastic surgeon, you have to dig mostly in these kind of nutritional deficiency. Don't take it lightly. So this patient just had the sleeve. You have to know what kind of sleeve, what kind of bariatric surgeon, if you're dealing with a bariatric surgeon, did the patient have re-sleeve, or it was a sleeve, or a bypass after sleeve? They all behave differently. So you have to take it as serious as the bariatric surgeon when they manage the patient during your post-op and pre-op optimization of the surgery. So they are also more prone for folate deficiency, vitamin B6, vitamin B12. This is more of the bypass procedure. Thiamine as well. Thiamine plays an essential role in metabolism of carbohydrates and branched-chain amino acids. Other vitamin deficiencies, they are more prone for vitamin C deficiency, mostly in the bypass group. And you all know the importance of vitamin C in increased collagen synthesis and angiogenesis. Other vitamin deficiency, vitamin A, vitamin E deficiency, which plays an important role in supporting the monocyte macrophages mediated response. Also, excess supplementation of vitamin E, on the contrary, can inhibit collagen synthesis and decrease the tensile strength of wounds, because vitamin E has anti-inflammatory properties similar to steroids. Iron deficiency, you have to do a CBC looking for your hemoglobin and hematocrit. Usually, I take a cutoff of hemoglobin value of 12 and hematocrit of 36 to operate on such patients. Other vitamin deficiency or nutrient minerals like zinc deficiency, which plays a role in fibroblast proliferation and collagen sensitivity. So when to operate? I started with this slide earlier. You have to have at least 12 months, 1 year after the bariatric procedure. Second, you have to have 3 months of stable body weight, BMI of less than 30, and most importantly, these patients have to be psychologically stable. Don't underestimate the importance of the psychological well-being of these patients. Key points for review with massive weight loss patients, length of the body contouring procedure, as I mentioned, I implied, and I really would like to emphasize on this point. You have to limit your operative procedure to 4 hours. We work with team, and it's the same team. It will be consistent in the same operative surgical cell. Need for multiple stage procedure to achieve optimal result, ability to go back and receive as needed, increased risk of smokers, scars, and these such patients can be placed, misplaced, migrate, can be asymmetric, especially most of these patients, they tend to gain some weight after surgery. And even your tightening is not that tight. There will be some element of loose skin, no matter how much tightening you're trying to do. So key points for review with a massive weight patient or massive weight loss patient is the recurrent skin laxity, as I mentioned, potential sensory loss, especially in the arms, inability to close the wounds, risk of deep vein thrombosis. I usually put the patient on intravenous fluid the moment they admitted the hospital. These procedure for me, it's a day surgery. I usually discharge them the second day, the second post-operative day, and I put them on Clexane. Potential for dehiscence, seroma, lymphocyte, importance of weight maintenance. This cannot be overemphasized. That's very important. These patients, if they cannot understand that they have to maintain their weight by exercise and proper diet, you shouldn't operate on such patients. and possibility of sexual dysfunction and woman vulvar dissection if you're doing some thigh lift or some work on the genital area. Pre-operative evaluation, you have to look at the body habitus of fat deposition, the morphology of the skin redundancy, the degree of the skin deflation, the body mass index at the presentation, the quality of skin envelope, and the scar placement. You have to decide beforehand where you're going to place your scars. So deflation can be mildly deflated, overly deflated, or non-deflated. Some patients, they don't lose a lot of weight after the bariatric procedure. So evaluation of the upper trunk, the evaluation of the upper trunk should include a thorough analysis of the breast, the chest, and the upper back. It goes as a one unit. So evaluation of the thigh and legs determine the degree of deflation, the excess skin, and the location and amount of excess fat. Evaluation of face, the face after massive weight loss patient usually ages prematurely. So you can see a 30 years old patient that she looks like 55, and you have to have, and you need to do a facelift on her. Facelift plus fat grafting. These patients tend to lose more volume in the mid-face and the skin more lax and less elastic, and marked skin laxity in the neck region as well. So the surgical goals in lower body procedure, flattening of the abdomen, recreating the umbilicus, elevating of the mons, creating a waist, especially in female patients, excision or liposuction of the lower back rolls, and defining the buttocks. I usually do more and more of fat grafting, and I use liberal use of implant. I usually bring patient after the bariatric procedure 4 or 5 months to do some session of fat grafting, lifting the outer anterior thigh, improving the inner thigh. Abdominoplasty objective, remove the extra skin and fat from the navel and pubic area, tighten the muscle of the abdomen, and liposuction. We are all aware of the high lateral tension suture of Ted Lockwood, mentioned in 2001. Paniculotomy, sometimes you don't have to do proper abdominoplasty. Patient, they have a redundant abdomen, they just want to remove this panniculus that affect their hygiene, they affect their sexual life. So you don't need to do tightening of muscle, no liposuction, just cut the skin off. So the surgical goal in upper body procedure, you have to reshape and augment the breast parenchyma to restore projection and fullness, to achieve appropriate nipple area complex position and size, to recreate, reposition the IMF, to reduce the skin envelope, to eliminate the prominent axillary skin rolls, to eliminate the mid and upper back rolls. Breast reshaping, asymmetrical volume loss in the massive weight loss patient, more of a deflated and flat appearance of the breast. Skin laxity is very apparent. The breast in male massive weight loss patients is quite different. So body mass index before weight loss and current, you have to compare it, degree of the nipple area complex ptosis, the amount of the breast production, the amount of hypertrophy, the amount of skin, excessive skin, and the loss of the IMF definition. Arm lift brachioplasty, remove excess skin that hangs loosely from the upper arms. Liposuction may be needed during surgery. These are some of my results. Actually, this is a post-op of a gentleman had a sleeve operation. So it's combined mastopexy and abdominoplasty. This is a patient who lost more than 70 kilos after a sleeve operation 5 years ago. So I did for him mastopexy as well as free nipple graft. And he has some transverse laxity as well as some element of vertical laxity. So I was wondering if I will just do only the belt without the fleur-de-lis incision, the vertical. And so, alhamdulillah, I was able to do just mastopexy excision of the lax skin and free nipple graft, and we did a belt on him. Without, and this is his result 1 month after the procedure, no vertical element, just free nipple graft and belt lobectomy. This is to underlie the importance of the psychological appearance of the psychological state of some patient. This is a patient, she had a sleeve and she had oropharyngeal cancer. She was irradiated and she had permanent fillers. Usually these patients who have permanent fillers, they are quite unique and you have to be very specific, very vigilant when you are treating them. And actually her scar looks inconspicuous. I cannot really see her scar. But these patients, usually they have very high standards and unrealistic expectation. I missed something that this patient was severely depressed and she was not treated. And this implies the element of really diagnosing psychiatric issues in such patient and offering treatment, proper treatment. There's some dehiscence. I usually see some photos for patients like this because usually they are outside Riyadh, so I receive it by WhatsApp or by email. So sometimes even I cannot tell which body part, but this is the patient. He just want to show you where the dehiscence is. So some gangrenes, some result of my patient mastopexy and thigh lift. My tummy up, so I'm running, so thigh lift. This is built. This is not the post-op, but this is a man. I do as well, like as mommy makeover, I do father makeover, post-bariatric. So this is the one of the previous one. This is the gentleman. Actually, this gentleman have a funny story. He was having this feeling after going to bathroom. He have a paniculus, so he have this feeling every time he want to clean his genital area. He was already programmed to have this rhythmic movement. He want to clean with this hand, and he was happy after removing this one, this paniculus, and had a liposuction. He almost automatically doing this, but alhamdulillah, it was already removed. Thigh lift, prenatal graft. Sometimes you have umbilical hernia, and you have to manage it if it's really small, or you call a general surgeon to address it for you. Some procedures. The cut, usually it's one cut, clear cut. Elderly, and if you have a vertical laxity, use proper use of implant. I use high profile and ultra high profile. I use Marcaine to decrease the pain, intraoperative. Built procedures, and this is a diagram. It helps not only in this field of post-bariatric or plastic or bariatric surgery. It has to do with your experience in general in any field that you don't know. You usually start with unrealistic expectation, and you inflated self-esteem that you know a lot of things. The moment you start doing the things, you discover how low of your or how small your information or your experience in that field. As it goes by and you gain more confidence, you start picking up, but it takes maybe a few years not to gain some experience and you to sharpen your skills. And thank you very much.
Thanks, Professor Dr. Muhammad, for this valuable talk. Our next presenter, Professor Dr. Mashal Nabuda. She is going to take a talk about the post-COVID wound management, pre and post wound care. Please, Dr. Mashal.
Hi, hello, thank you. Thank you for this wonderful introduction, and it's a great pleasure for me to be part of this very well-known conference and to share our experience together with you. I'll be talking about the impact of COVID-19 on wound care and showcase the hemicellulose membrane with the nanobiotechnology in chronic wound and trauma cases. As you all know or have been in contact with, we all know that the COVID-19 has a great impact on the wound healing and on other comorbidities of the patient. So it helps to have a burden on the patient's overall health, leading to increased burden on the wound healing process. So it is well known that the timely wound care is important to help improve the wound healing process. So it is very important to know when to direct or start the treatment to the wound and to exactly know when to start the debridement or to plan the healing process. So my first case will be a pressure ulcer case due to the complication of COVID-19. And the patient is a female who is 39 years old who was admitted to the hospital due to the complication of COVID-19. And she was intubated and bedridden for over a month, leading to the development of pressure ulcer. And as you can see here, the wound is, the pressure ulcer is stage 4, and it is about 20 by 17 centimeter in width, and as you can see, it is covered by slough and unhealthy tissue. This case is the courtesy of Dr. Pierre Basmadi in Brazil, who have already had a long way in managing cases of wound by the nanotechnology. As you can see, the wound has been gently cleansed with non-cytotoxic dressing or wound cleansing solution. And the initial use of hemicellulose membrane was started on April. And as you can see, after 1 month, the major reduction in size of the wound with a reduction of the slough material that is appearing on the wound. And after only 2 months of the application, the wound have completely closed and healed. My second case will be another pressure ulcer, also due to the complications of COVID-19. And this patient is a male patient who's 43 years old and who was admitted to the hospital because, again, of the infection of COVID-19 at the beginning of May. The patient was also intubated where he developed the pressure ulcer. This pressure ulcer, as you can see, it's stage X, so you cannot see what's going beyond it. And it is about 22 by 16 centimeter, and it is about 10 centimeter in depth. This wound was infected, and it was a very difficult wound to heal. So the initial stage was to do a debridement and cleaning, and the patient was, because of his deteriorated health condition, this journey of healing took a longer time with us. So as you can see, the treatment started in June, and actually after a couple of dressings, as you can see, the wound is shrinking in size, but it was still having a lot of pockets and a lot of tunnels, which rendered the healing process to be a little bit slow and delayed. In October, we have reached to almost complete healing of the wound. My third case is actually a case that I have directly supervised and worked with. It's of a child who was 6 years old, and he came from Oman as a visit with his parents. During his visit, he had contracted a motor vehicle accident. The car ran over his foot, and the mother was so much concerned, and she was reluctant to take the patient for surgical treatment, and she was strongly against it. So what we did is that we cleaned the wound. Actually, the first couple of days, we used the silver cream dressing, and we managed, as you can see over here, I'm sorry, the pointer is not showing, but the bone is showing, and there is a lot of tarry residues on the wound. So after constant treatment, and this is 2 days after the admission with silver dressing, we have started the hemicellulose membrane treatment. We were doing regular, just cleaning with very mild wound cleansing solution. And we applied the hemicellulose dressing using the biogel that comes along with it for a couple of weeks in order to reduce the infection burden. And this is the initial stage of dressing. It was very mild, and the patient didn't show any signs of pain or irritability while doing the dressing. So this is the application. The patient had initially alternate day dressing with this hemicellulose dressing. And as you can see, the upper part of the wound have started already to heal, although it was still under the membrane dressing, but it shows that it is, because it's more or less superficial, The wound healing process in the upper part of the wound was very easy, and the patient didn't have any complication in that area. But also in the deeper part of the wound, as you can see, the granulation tissue have started to appear and to cover most of the bony area. The wound started to heal well, and as you can see, the healthy granulation tissue started to creep on top of the bone to cover it. The child was discharged then, and without the need to any surgical intervention, and he was following with us in the clinic. After a while, he started to do once in a week dressing, which was very much easier for the child and for the parent, since they are coming all the way from Oman. The wound continues to shrink in size, and as you can see in this area on the foot, that the wound has completely healed, except for small areas where there is some slough and debris. And this was the last visit to the clinic, which was in July, while the wound is almost completely healed, and the patient didn't need to go to the surgery. After that, he started to follow up with us for laser resurfacing for the scar on the foot. These are my references, and thank you so much for listening to me. Thank you.
Thanks, Professor Dr. Mashal, for this nice talk. Actually, we reach our end of the presentations. So, any questions from the audience for any of us? For Taysir? For Dr. Muhammad? For Dr. Mashal? Okay, thank you, and let me end this session. Thanks for all. Thanks, Professor Dr. Marwan, for your kindness. Thank you.
Thank you so much, Dr. Taisil Abdulal, for your time and patience. We now end session 3. I would like to repeat my announcement. Kindly, I request all the speakers to collect your certificates from the registration counter. And as we say, photos are return tickets to memories otherwise gone. So may I request everyone to please come on the stage and have your photographs clicked. Can I please request the photographers to be around? Check. Ladies and gentlemen, you can now please proceed for your lunch, and I shall see you at 1:30. Thank you. Check, check. Namaste, Adab, Assalamu alaikum. Welcome back from the lunch break, gentlemen. May I now please request moderator Dr. Sherif Fatih to join us? Welcome, Dr. Sharif. Mic over to you.
Good afternoon, everybody, and I think it's a hard time after lunch, and there is still some people didn't come. Anyhow, we'll start our session today. I'm Dr. Sharif Fathi, consultant plastic surgery in Saudi Arabia, Dr. Salman Faqih Hospital, graduated from Ain Shams University. And at the beginning, I want to thank Dr. Marwan and Dr. Muhammad Qahtani for inviting me for this prestigious conference. And we start the first session with Professor Dr. Muhammad Qahtani. He is senior consultant plastic surgery in National Guard Hospital in Jeddah, and one of his interests in burn care. Dr. Muhammad, please, the phone for you.
Good afternoon, everybody. Thank you, Dr. Sharif. I'm going to talk about today is burn injuries in pediatrics and child. When we raise the flag to have or considering child abuse. Next slide. Have no conflict of interest. Goal and vision when we treat patients, considering pediatric patients, to detect if there is any element in history that indicate of child abuse, and our vision to stop child abuse. And when we mentioning child abuse is when something failing to harm the child or put the child at risk of harm. And to highlight on child abuse, you have to mention it could be a physical, sexual, or emotional, and neglect is also a form of abuse. When defining what's a physical abuse, it's a part of accident and in the consequences of a physical injury, and most often represent unreasonably severe corporal punishment or unjustified punishment. Usually happens when a person, part of the family or who is guardian for the of the children, get angry or strikes, and throw the child intentionally or assaulting them, and such as burn or biting or twisting limbs and torturing a child, and also include in this a category of child abuse. Burn injuries cause pain, scarring, and deformity. And we know up to 10% from burn injuries could be a child abuse. 10% of hospital admission of children with burns or admitted to the burn unit considered child abuse. And they are younger, they couldn't talk about what's happened to them. And they tend to have a longer hospital stay and higher mortality rate. The child burn victims almost always under the age of 10, with majority under age of 2. The commonest site involves the gluteal region, perineum, with the hot tap water as the cause of burn. Abused infants and toddlers have much higher mortality rate than unabused children, and this is the fact. And as usual, mechanism of injury could be a scald burn, chemical or electrical burn. And here is some of indicators of abuse when you take a detailed history and you find there is a discrepancy in the history between what's mentioned to you and what's really, you could see it as a clinical finding in terms of mechanism, location, time to seek medical attention, the witness, previous trauma or admission to the hospital, immunization status, and status of routine medical care, and you have to find the socioeconomic status and family background history. Here's some diagram show where is you could see if there is a child abuse, where it's mostly in the lower part of the body, including the genitalia. When you conducted a clinical exam, you have to do a cognitive and development assessment. You see if there is an area of healed burns, multiple area of burns, the area of demarcation, evidence of sexual abuse. And here is some what they call it a baby gram when we do a long bone, chest, and skull radiographic series to find if there is any fracture or any trauma. Unfortunately, there are no specific laboratory studies that will help to distinguish that it's a accident from abuse. Here is we have look at a checklist when there is a considerable injuries of children to eliminate if there is any evidence of a child abuse. You have to go through that. This checklist will help you to organize your thought and investigate more with to find out if there is any child, any considerable status of abusing. Here is some sort of burn marks, if there is a hot or knife or girdle, and this is a cigarette burns marks like this patient. This is when it's considered a circular demarcated, also using you know, like a spoon or forks type of burns. Immersion of burns or immersion burns is a concerning of abuse. Why? Because it's located in some area in the buttock area, perineum, and it's usually circumferential. Absence of splash marks usually is well demarcated, and it have an oval or a well-organized shape of burn, sparing part, and usually involve the genitalia. Like such this patient, this is how the locks of the burn here is in the lower extremity. Chemical burns, also in household chemical burns, alkaline burn, more severe injury than acidic. And usually they have the skin is stained by black hydrochloric acid, yellow binitric acid, and non-acid sulfuric acid. Burns as deeper, and usually this is also a burn involving genitalia. I'll throw some cases of immersing intentionally the baby into hot scald water. Here also, if such a case when you have a child with negligence, mostly you're taking a history and you find the burns, they have no witness what happened, or there is no one take care of the baby at home, and usually we take this in consideration. This is a baby arrived to the hospital. The burns where they are deforced, and they have not really given the truth what's happened, and we found discrepancy. And while the patient, the children hospitalized in the burn unit, we look at how they deliver the care, and we found that they are not intention toward saving the child. They refusing treatment. We consult the social services, and that's called SCAMS team, where they take care of the child abuse. Unfortunately, this baby get into, because delayed treatment, get into infection and end up with like a necrotizing pattern. We took her to the alpha debridements, or significant life-threatening injury because parents were they interfere with the management. And we took a decision upon the guardian of the patient. We took her to the OR for aggressive debridement, and we saved the baby life. And we report that to higher authority. And in case of electrical burn, usually there's, as you know, there's high versus low voltage burn, and usually involve a deeper and destructive effect. Such this baby was a child playing in the ground without attention from the family to save him, and he ended up with high voltage electrically injured and ended up with bilateral amputation of his arm. A team approach to child abuse with addition of specially trained group is important to ensure prompt recognition and further follow-up, and include a law enforcement, social services, and also our role as a clinician. Infants who do not cruise cannot bruise, and usually we tend to see the bruise or bleeding disorder and abuse. All we need is for our children love and care. Thank you.
Thanks, Dr. Mohammed. And I think it's very, very important subject because the psychological impact for these children later on, it will be very depressed. And a child or community awareness about this subject is very important. Thank you. Now it's my honor to introduce the second speaker, Dr. Mustafa Al-Masri. He is assistant professor in Suez Canal University in Egypt, and now he is working in the prestigious burn care center in Sweden. And his interest in burn management, and he will present the experience, his experience as multinational experience for treating partial thickness burn with biosynthetic cellulose. The floor is yours, Dr. Mustafa.
Thank you very much, and thank you for the nice invitation to this wonderful conference. My name is Mustafa Al-Masri. I'm a plastic surgeon. I work in Sweden, in Linköping Burn Center. I have nothing to disclose. And my talk today is mainly about our experience with biosynthetic cellulose as a dressing for superficial burns. And this study that I am today talking about is a multi-center study done in the two national burn centers in Sweden, in a city called Linköping, where I'm working, and another national burn center in Uppsala, where in the bit north of Sweden. This is our burn center, Linköping University Hospital in Sweden. And as well, part of the study was done in Ismailia in Suez Canal University Hospital. So I will report findings from all the three centers today. The first study was a multi-center study in Sweden about biosynthetic cellulose compared to porcine xenografts in the treatment of partial thickness burns, published in Burns. And another study which is based about our experience with biosynthetic cellulose for about 3 years in Linköping as well. And then the third study, which as well published in Burns, with the treatment with the biosynthetic cellulose compared to silver sulfadiazine. And this was carried out in Egypt, in Ismailia, Suez Canal University. As we know, mainly in Europe and the US, the pre-meshed porcine xenografts were used for actually many years as a dressing for superficial dermal burns or burns from the second and deep second-degree burns. And as we all know, it was associated with low infection rates. Pain was remarkably decreased with patients treated with this technique, fewer dressing changes, and faster reepithelialization. And there is lots of publications actually all over the years which have been studying the porcine xenografts. But usually there is concerns when using animal products in the care of patients. Nevertheless, the infections, some cultural and religious aspects as well. So all these factors led to the need to search for other alternatives that can work likewise, at least. And that dressing that I'm going to talk about today, which was actually developed in the laboratories of our university, is the biosynthetic cellulose, the BSC, that I'm going to mention it in this presentation. And it's actually a polymer that is synthesized from bacteria, Acinetobacter cilium. And it was investigated previously in our study center from the beginning. So it presents high water absorption capacity, resistance to degradation, and as well good permeability. And most of these properties come from the three-dimensional nanofibrillar network. As well, in the lab, we have tested to culture other types of cells on the top of the cellulose, like the adipose stem cells or fibroblasts, with very good attachment and growth, actually. So, in partial thickness burns, those burns that doesn't need surgical excision, when you apply a dressing, which is a membranous dressings like porcine xenografts or biosynthetic cellulose, they will allow the reepithelialization underneath. And as the skin reepithelize, then the dressing will peel off spontaneously. And it takes about 2 weeks usually until the whole wound is totally healed. While the deeper burns, like the full thickness burns or the deep dermal burns, the dressing will be sloughed, and then you can actually proceed to excise the deeper burns that will not heal spontaneously, actually. And here is an example. It's a superficial dermal burn covered with biosynthetic cellulose. And as you see in the picture C, the sloughing starts and the healing underneath is quite nice, actually. And this is in a period of about 1 to 2 weeks. While in third degree burns, when you tend to excise the burn, as this burn on the back, then you can use it as a temporary skin substitute until you can put your skin grafts later on. So you can use it as a skin substitute, a temporary skin substitute, and then apply wide meshed skin grafts as the routines in different burn centers. So the first study aimed to compare the clinical performance of biosynthetic cellulose compared with the porcine xenografts in the treatment of partial thickness burns in adults, actually. And the primary outcome was the time to healing, and the secondary outcomes were infection, pain, impact on everyday life, costs, length of hospital stay, and long-term scar follow-ups, which was evaluated with POSAS score. The study was approved by the Swedish Ethical Review Authority with this number and registered in clinicaltrials.gov, so you can find it on the internet. And it was a prospective, open, randomized clinical trial, included 24 adults over 18 years, admitted to the burn center in both Linköping or Uppsala in Sweden between June 2016 and November 2018. And the participants who had been admitted within 72 hours of injury were included in this study and who were evaluated as a partial thickness burn. The two dressings that were compared is the biosynthetic cellulose, EpiProtect, from Linköping, Sweden, or the porcine xenografts, which come from Sweden as well, from Mölnlycke Healthcare in Gothenburg. The study dressings were examined 2 to 5 days after applications, and we have recorded all the variables like healing time, pain, length of hospital stay, as I have been mentioned before. And this is an outline of the patients. There was no difference in the groups, both treated with porcine xenografts or biosynthetic cellulose in all the demographic variables. And as we saw that the time to 95% healing of the burn wound was similar between the two groups. There was no difference, actually. So the biosynthetic cellulose performed quite similar to the porcine xenografts. And the median time for healing in the xenografts was 19 days, or 18 days in the biosynthetic cellulose. The secondary outcomes didn't differ much. It was the same, almost infection frequency, the C-reactive protein, the antibiotic use. The duration of hospital stay was a bit shorter, actually, with the BSC group, but was not significantly different anyway. The secondary outcomes, the pain, there was a tendency for lower pain scores in the biosynthetic cellulose group. The costs, there was no difference, actually. And with the scar follow-ups, the patients treated with porcine xenografts scored higher in the item of sickness and relief in the POSAS scale, both on the observed and the patient scale. This is the outline of the POSAS score. And this is one case which was included in the study, which was treated with porcine xenografts. This is the patient from the beginning, and then application of the meshed xenografts, and then the sloughing, and then the healing, and then at the 12-month visit after the study was finished. This is another patient on the arm, superficial second-degree burn, little deep on the wrist joint, applied with the BSC and followed up until healing. And the conclusion that we didn't find actually differences between the biosynthetic cellulose and the xenografts regarding all the variables that we have been recorded in the study. And after 1 year, the patients who were treated with the xenografts have been actually showing, I can say like it's a patient evaluated experience that they have worse scars in the item of thickness and relief. The next study was the comparison of the cellulose or the biosynthetic cellulose with the silver sulfadiazine for treatment of partial thickness burns. And there were 20 patients included in each group, and it was as well a randomized control trial. We have also recorded the pain, the time to healing, but the pain was assessed with another score, the FLACC. And here is the consort flow chart, including the patients who were included in the study. And the other variables that were recorded, the TBSA, the sex, the age, the clinical signs of infection, and the time for healing, and as well the length of hospital stay. One of the patients, after debridement, application of the BSC, and until healing. Another patient with face burn as well. And as we saw here, the median TBSA of the patients who were treated in this study was about 9%. The dressing changes for the BSC group was only one dressing change compared with 9.5 dressing changes for the silver sulfadiazine. But this is almost expected. When you use silver sulfadiazine, you have to change it quite frequently. And the regression have shown that it was a shorter hospital stay for the patients treated with the BSC, and the pain was significantly lower with the BSC. But actually, the rate of healing, we didn't see a significant difference. It was a bit quicker in the BSC group, but we didn't see any statistical difference actually between the two groups. So, thanks a lot.
Thanks, Dr. Mustafa, about this nice presentation. And it's my honor to introduce the second speaker, Dr. Joanne Janker. Dr. Joanne has a number of research projects in the field of wound management, and he will talk today about antimicrobial peptides for treating infected wounds. Please, Dr. Joanne.
Hi, thank you for inviting me to give this talk. Of course. Yeah, I'm going to talk about antimicrobial peptides for the treatment of infected wounds. So I'm actually from the same city in Sweden as Mustafa. Although he's at the burn unit, I'm at something we call experimental plastic surgery. Yeah. So obviously, wound infection is a big problem. First of all, pretty much all wounds become infected. And we all know that infection prevents healing or leads to even worse complications with a very increased mortality and morbidity. And this is especially complicated by the onset of antimicrobial resistance. So we usually call this the post-antibiotic era, where quite rapidly we're actually running out of antibiotics to treat infections. And there are some specific bacteria that you all know maybe that are the usual culprits in this that you can see on the bottom. And according to, this is some recent numbers that I found from the Lancet, about 3,500 deaths globally per day are directly related to antimicrobial resistance. And the WHO has a quite striking quote where they say that antimicrobial resistance is one of the biggest threats to global health. So this is obviously something that we should do something about. And one possible solution to this is kind of the focus of some of our studies, namely antimicrobial peptides. So what are these peptides? Well, first of all, they're found in pretty much all life forms around the globe. And they can be said to be part of the innate immune response. So these are short peptides, and they're effective against sometimes or most often bacteria, but also viruses and fungi. And the mechanism of action varies, but frequently they're membrane destabilizing, hence they just rupture the bacterial membrane. We also seen some antimicrobial peptides. I think there are about 3,000 different ones described now that can disrupt biofilm. So that's also extremely interesting, of course. But the key here is that these antimicrobial peptides have a very limited resistance development, meaning that microorganisms have a hard time developing resistance against them. So hopefully we can kind of keep the activity of these antimicrobial peptides. So there's about 3,000 different ones. So how are we going to know which one we're going to study, right? So we kind of tested a few different ones, and we ended up focusing on a particular one, which is called plantarcin NC8 alpha beta. And it's actually two peptides, and it's produced by a Lactobacillus plantarum, so one of the good bacteria. And so it contains two subunits, the alpha and the beta peptide, and it's grouped into a group called bacteriocins, which means that it's bacteriostatic, and it's from it's a plantarcin. So one first kind of important point is that this is not, seems to be non-toxic for human cells at least. And we've seen in some in vitro studies that it's effective against Staph aureus and Staph epidermidis, which apparently, especially Staph aureus, is probably one of the most important targets for antimicrobial treatment. We also know that this AMP, antimicrobial peptide, the NC8, leads to increased permeability in the bacterial wall. And we kind of hypothesize that this leads to increased antibiotic efficiency, because one of the resistance mechanisms of bacteria is just preventing antibiotic from getting in or pumping out whatever gets in. So if we just increase the permeability, we probably get a higher intracellular concentration in the bacteria of the antibiotic. So we designed an in vitro test for this, where we basically cultured human keratinocytes together with Staph aureus. And then we used some various fluorescent reporters to measure the amount of bacteria and also monitoring cell death of the keratinocytes. So I'm just going to show you some results from that with the focus on the amount of bacteria. So if we just infect our cells and measure the amount of bacteria over time, time is on the x-axis, we see that after about 10 hours of inoculation, the amount of Staph aureus increases quite exponentially. And then we tried adding antibiotics to the mix here as well. And we basically saw that we could just delay the expansion of the bacteria using antibiotics. So this is, of course, what we expect. But then adding the peptides without antibiotics, just the peptides, we see that we actually have quite a nice effect of the NC8 peptide, or both the peptides together, rather. But the interesting thing is confirming the hypothesis of the synergistic effect with antibiotics when we add both of them together, and then we get this picture. So basically, it delays it a great deal, and probably, or my guess is that the actual expansion of bacteria that shows up at around 55 hours is probably due to the peptides just running out, basically. So this was great, some great results that prompted us to kind of continue looking into this peptide. Excuse me. We did some modifications of these peptides, and one of the key things here, which we could kind of see on the previous picture, is that these peptides they're small and they have quite short half-life because proteases will kind of metabolize them really rapidly, I would guess. And in an infected wound, we have a lot of proteases, both from the cells in the wound, but also from the bacteria in the wound. So we came up with the idea of synthesizing these peptides using the mirror image of the molecules or the amino acids. And the smart thing about that is biologically, it behaves the same. So it has the same antimicrobial activity, at least when tested in vitro. But it's non-degradable by proteases because our proteases that we have natively are only of the L shape kind. So they can't really cleave these D-enantiomer peptides. And we tried this by just using a simple trypsin assay where we added trypsin and then just waited and saw what happened to the peptides. So that was an interesting concept that we kind of continued studying. So to study the efficacy in vivo, we used a porcine wound healing model. So here's a picture of the back of a pig with, I guess it's 30 small wounds. And each of these wounds were inoculated with about 100 million Staph aureus. And we waited for 48 hours. And then we started treating them with peptides or other control groups. I'll show you that soon. During a week's time or something like that, we took quantitative cultures to see the amount of bacteria. We look at histology, and I'll show you one slide of that. We also did some immunohistochemical evaluation, looking at inflammatory cell infiltration and stuff like that. And we can test some mechanical parameters to see what's going on with the kind of healing of the wound. I won't show you these two last points there, but yeah. Okay, so how did this work out? Well, on the, maybe, yeah. So on the y-axis here, you have the amount of bacteria per gram of tissue. And we can see after 2 days of inoculation, we start off with about 10 to the power of 6 colony-forming units of bacteria per gram. So that is above the threshold where we would call this wound infection. And this will significantly prevent healing and cause problems in a clinical perspective. And these are just control groups. So we either just treat it with sodium chloride, so basically no treatment, or we administer systemic gentamicin, or we use local gentamicin. And as you can see, the systemic gentamicin, which is the black dots, kind of reduced the infection somewhat, but after biofilm formation and poor vasculature in these wounds, I guess the effect isn't that strong. So all in all these three groups were pretty non-successful in reducing infection in the wounds. So then we add the peptides, either just the peptide or the peptide together with antibiotics. And this is the L shape, so the normal native shape of the peptides. And basically we see after a few days a quite marked reduction of infection. So looking at only the peptide, which is a white box here, we get down to about 10 to the power of 5 or something like that. So it's a reduction, which is not fantastic, maybe, but combining it together with antibiotics, we see a clear reduction. And at day 10, which is actually 8 days after treatment started, we're down to normal flora levels of bacteria. So that was great. But then we kind of wanted to test our mirror image peptides as well in this system. So that looked like this. So basically here, in a very rapid time frame, we get more or less complete eradication of wound infection. And these peptides are, as I said, not proteolytically degradable. So probably we maintain a very high concentration. So this was nice to see. But a lot of questions kind of remains to be answered, obviously. But I'll show you the histology. This is just some snapshots after 10 days. So that last time point where we have in the control wound, basically no healing going on. And to the right on the top row there, you can see a lot of bacteria in the tissue. Maybe you can see them at least. That's the small black dots, both in the epidermis and the dermis. And on the bottom row there, we have the peptide and the entire wound is healed and nicely reepithelialized with a thick neoepithelium and also very little or even no bacteria visible. But that was promising results as well. So in conclusion, we kind of think that the plantarcin NC8 alpha beta is highly efficient in treating wound infection, and that it has significant synergies with antibodies, and that the enantiomer mirror image is stable. So a lot of gain in efficiency using that one. But there's a lot of stuff still left to do. I mean, we pretty much focused on Staph aureus here, so we want to obviously test additional pathogens. We're kind of ongoing experiments are testing Pseudomonas aeruginosa and some strains of Acinetobacter. But we also have done some experiments primarily in vitro, evaluating multi-resistant strains of bacteria. If we could administer this systemically, that would of course be elegant in terms of treating septicemia or things where we can't administer it locally. We have some homework to do with the toxicity profiling of the mirror image enantiomer. We haven't done much of that. We've done it in cell culture, but we really need to look at systemic toxicity there. And another thing that we're currently looking into is combining this antimicrobial peptide or other peptides with wound dressings. So it will be all-in-one treatment solution. And the next speaker is actually going to talk more about that, so I won't spoil that for you. Yeah, thanks.
Thanks a lot, Dr. Joanne, about your scientific and evidence-based research, and I hope it will be clinically applied soon. Thank you. Now, it's my honor to introduce the next speaker, Dr. Daniel Ali. Dr. Daniel's research interest involves design and development of molecules, soft materials, and hyper nanoscale components and devices for a wide range of applications in wound care. And he will present today antibacterial biosynthetic nanocellulose wound dressings. Okay, Dr. Daniel, the floor is yours.
Very much for that kind introduction and for the invitation to come here to give a talk about our work. So I'm a material scientist, so I'm going to talk a bit about how to functionalize nanocellulose-based wound dressings. So I'm also from Linköping University in Sweden, located here in the Scandinavian peninsula, south of Stockholm, the capital of Sweden. So this is collaborative work between the previous speakers and a few other Swedish professors and research group and my research team. This is work primarily by Robert Selgård, Elisa Satterin, and Rolf Eskilsson. And together in this team, we're developing new strategies for dealing with essentially improving properties of materials for wound healing, which include new materials and new functionalities in these materials. And as you already heard, biosynthetic nanocellulose, it's started to be quite widely used for treatment of burns and also for non-healing wounds, chronic wounds, and as temporary skin protection. And if you look at these materials under an electron microscope, this is what you see. So you see that this is a nanofibrillar material with dimensions roughly 40 to 60 nanometer in diameter and up to 10 microns in length. And cellulose is one of the most abundant materials on Earth. So this is produced in a biotechnological process in this case, but you also have cellulose present in plants, of course, and this is what most of Sweden look like. We have quite a lot of forest and trees, and you can also produce nanocellulose from trees or plants as well. The difficulty there is to obtain materials with similar or same properties as these biosynthetic materials, but this is also work that we're doing together with collaborators in order to have a more cost-effective process for producing these materials. The biosynthetic cellulose, as you recently heard, it's a flexible and quite mechanically robust hydrogel material, which means it's comprised of primarily water, 95% water, and this facilitates moist wound healing. And since it's also very flexible and very thin, it also adheres and conforms to wound. It's it's hemostatic, it's permeable to gases, and it prevents fluid loss. And the tight nanoscale structure prevents also bacteria from entering from the outside. And we have, among others, used it for treatment then of both acute and chronic wounds. And this is from a case study with 8 patients. And what's interesting here is that we have, as humans, no enzymes to degrade cellulose, why these materials remain intact while in contact with the wound. And it's also, I mean, highly performing as a material, is biocompatible. So there's limited need for dressing changes. And in this case study, there was very few dressing changes during the treatment time. But then, of course, if there are infections, there can be problems, and especially if these bacteria forms biofilms. And there are increasing issues with multi-drug resistant bacteria, and these bacteria then prevents healing and contributes to chronification of wounds. So what we are interested in is developing simple methods for, I mean, in the previous case or in the case here, you see that the infection is quite obvious, but there are cases where you have bacteria and it's not as obvious to the eye. You need to do swabbing, which is time consuming and costly. So we are looking at ways to essentially see early signs of infections by built-in sensors in the dressings, and also developing means then to provide treatments for these infections. And the difficulty for us as material scientists is that cellulose is chemically inert. There are no functional groups to work with. We need to treat the cellulose quite harshly in order to create possibilities to do any chemical modifications to the materials, which we don't want necessarily to do, because it's a good material when you don't want to destroy it by doing a lot of chemistry. So we instead starting looking at modeling interactions between cellulose and bioactive species, and in order to identify conditions where these bioactive species adsorb physically to the material. And we can do this quite efficiently. So what we see here in the cuvettes here, you have a red solution, and essentially all those species under these conditions are adsorbed to the BC dressing are at the bottom of the cuvette. So it's possible to functionalize the material with various species, just tuning the conditions in various ways, for example, changing the ionic strength. And in this case, we used inorganic nanoparticles, both because these are easy to see in an electron micrograph, and we can see that they penetrate into the nanoporous structure of the material all the way through. But also, since you can provide a lot of interesting functionalities using inorganic nanoparticles. In this case, we used pH-responsive nanoparticles. And this is of relevance for wound care, since the pH in a wound changes quite drastically in case of infection. Typically from healthy tissue, which is roughly around 5 to 6, up all the way to 8, 9 in pH. And these color dots you see here, it's functionalized nanocellulose subjected to different pH and modified with these pH-responsive nanoparticles. And also through this functionalization, the material retains its good mechanical properties. And when applied to a non-infected wound in a porcine model, we can see that the pH is around 6, whereas in a wound infected with Staph aureus, it changes color dramatically. And with high contrast, so you can clearly see that this is a different pH indicating infection. In addition, you can also load metallic nanoparticles, and silver is a metal that is widely used in this context to eradicate infections. And you're typically used to see this shiny metallic silver-looking dressings. When using nanoparticles, they have different optical properties. So what you see here instead, since these are nanoparticles, that the dressing is yellowish. And that's due to their small size, but also because of this small size, they have large surface to volume ratio, so they release quite a lot of silver, which enables us to also effectively kill bacteria that come in contact or in close vicinity of these dressings. But then we're also very interested in these antimicrobial peptides, or AMPs, or AMP mimetic peptides. So fairly short, in this case, synthetic peptides. And they disrupt the lipid membranes, as Dr. Junker recently just said in his talk. By permeabilizing the membrane of the bacteria, they also kill efficiently the bacteria. And this is what it looks like under an electron microscope. You see that the bacterial membrane just more or less explode when in contact with these peptides. And we were interested in seeing if we can use the same methods for absorbing by physical interactions these peptides to nanocellulose membranes. And again, optimizing the conditions for these interactions, we can load fairly high concentrations of peptides and also release them under relevant conditions, resulting in concentrations above the minimal bactericide concentration in order to kill bacteria like Staph aureus. But in order then to further bump up the concentration, we looked into possibilities to increase the effective surface area of these materials. And one way to do that is to, again, use inorganic nanoparticles. In this case, a vehicle that is widely used in drug delivery, mesoporous nanoparticles that typically have a huge surface area, up to 1,000 square meter per gram, whereas the bacterial nanocellulose has a surface area of 100. And by combining these two high surface area materials, we can create nanocomposites that can load a lot of drugs and killing bacteria as efficiently as the free peptide in solution. So just to conclude, it is indeed possible to add new functionalities to biosynthetic nanocellulose wound dressing, and also without using any complicated chemistry that can influence or have a negative impact on the material's properties. We have, for example, then looked at possibilities to functionalize these materials for pH sensing, cellular release, and release of antimicrobial compounds. And yeah, we're looking forward to investigate this more in order to find new ways to diagnose or detect infection and also to treat infections. So thank you very much for your attention.
Thanks too much, Dr. Daniel, about this highly specific scientific research. And thanks for this Sweden experience about application of biocellulose and the effect of antibacterial polypeptide and integration of this in wound dressing. Now it's to open discussion with our speakers. First speaker, Dr. Muhammad Qahtani. We have any questions about? Okay. For Dr. Mustafa Al-Masri. I want to ask Dr. Mustafa, please. What's your explanation about the scar or better scar in using porcine xenograft compared to biocellulose?
I think I don't have a scientific explanation actually, so I will not give you concrete data. But I think the inflammatory response that we see with the porcine xenografts is much more stronger than we see with other dressings. So I think the inflammation in the wound can lead to a bit of change in the healing qualities of the skin then, and that's why the scars are a bit worse. But we have actually taken some biopsies from the scars previously, from different dressings and from different skin parts, but we haven't seen any histological differences actually. So this is our theory, but I don't have, as I told you, concrete data or a concrete explanation why. It's just a clinical phenomena that we have been noticing.
Thank you, Dr. Mustafa. Any question for Dr. Joanne?
I have a question.
Please.
Here.
Please.
Thank you for the nice presentation. My question is, do you think in the future the peptides will be as a systemic or local application? Because you mentioned that you are now going towards the local application because of the toxicity. But what do you think the future will be? Systemic or local? And why?
Thank you. Great question. So I guess this is a little bit of a personal opinion, and I'm interested in wounds and wound infection. And in the case of wound infection, I highly prefer local treatment. And you kind of made a good point on why, and that is we can use a tremendously high concentration locally without risking systemic toxicity, because more or less nothing will be uptaken systemically from a local treatment. We've kind of seen that it's very hard to detect any uptake of any drug you put into a wound, really. But of course, there's a lot of other types of infections that aren't necessarily in wounds. I mean, today and yesterday, we're talking about wounds, but if you have a systemic infection, then a topical administration won't work. So, but for my interests, I prefer local, just due to the high concentration I can achieve without risking toxicity. But it is important, obviously, to look at systemic delivery as well. Yeah.
My second question is the toxicity. Is it due to the concentration of the peptide which you are using? So you will use in the future less peptides, so there will be less toxicity, so the result will be better? Or is it related to something else?
So in terms of this peptide, in particular, the NC8 alpha beta, we haven't seen that much toxicity at all when looking at fairly simple in vitro systems where we just add them to human cells. It actually seems like it could be the opposite. So it actually could cause the cells to be slightly more proliferative. So the opposite of toxicity, I guess. But obviously we haven't done that systematic studies that we can talk about exactly those response curves yet. And so we might see it that we're fighting a little bit against the infectious disease doctors here, because they want their antibiotics. I mean, they don't want to give antibiotics, but they like antibiotics anyway. So probably combining a very low dose of peptides together with a hopefully very low dose of antibiotics, perhaps also antibiotics that may have some resistance profile development, but with the help of peptides can actually be effective again. That would probably be a good way forward to bring the infectious disease doctors on board, kind of. But maybe just using peptides and then obviously determining the minimum effective dose. And we have looked into that somewhat, but yeah.
Okay.
Any more questions? Questions for Dr. Daniel?
I have a question for Dr. Daniel. Regarding the pH level, I remember since more than, I would say, 10 years, everybody are trying to avoid cleaning the wound with, let us say, betadine, chlorhexidine, and you name it. And then they are using more alkaline products, which they say that it's a better, which I believe in that also, which they say it's better for wound cleaning and it doesn't create a good environment for the bacteria to grow. But in your slide, you show that the bacteria will grow in pH 8, which is more alkaline. So
And
how
it's
you
the-
can explain that?
It's the bacteria that creates that pH. So it's the infection, a way for the bacteria to essentially create a microenvironment where the bacteria can thrive. So whether probably these disinfectants
I
are-
believe in what you are saying here, but my question is the solution which we are using right now. Do you think it's true, like what they are saying, that to use these alkaline solutions which removes the bacteria, because anyhow the bacteria is going to live in that environment?
I guess it's pH dependent. If you go above their preferred pH, you can definitely disrupt their viability to a certain extent, but there can also be other components I can imagine in those cleaning solutions that also have an antibacterial effect. But I don't want to speculate, but that could be.
Because in
if it
old
works,
time,
it works.
Because in old time they used
Yeah.
to tell us to use low pH, not very low, but low pH to kill the bacteria. But later on they told us we have to go for the alkaline, so we will not harm the tissue. At the same time, it will not be a good environment for the bacteria. This is what I understood from the beginning of 2000 when they shifted to the alkaline products.
I don't have a good answer to that, but it's definitely a very interesting question.
Dr. Karim has comment, please.
Yeah, we are using in Oman our experience, of course, in Burns unit there. We are using a mix of acetic acid, diluted acetic acid, plus gentamicin. And give a great effect. So acidity will kill all the bacteria and give a great effect, especially for superficial infection. We are using now for like 3 or 4 years and give a good result with acid, diluted acetic acid. This is our own experience in Oman, and we tried over meek and on normal wounds where there is a superficial infection. We wash on daily basis. We wash it with acetic acid diluted plus gentamicin, and it gives a great effect.
Yes, we used to do more acid products in the beginning, but later on in the beginning of 2000, they told us not to use it and use more alkaline, so to be less painful for the patient and less harm to the tissue, and at the same time there will be cleaning of the wound. This is what I heard.
Actually, acetic acid is the vinegar at home, so it's
Yeah,
not painful
yeah.
for the patient, and we can dilute also, so make
Yeah.
a bigger effect.
We used to do that.
Yeah, and give a good effect.
Especially
now.
for the Pseudomonas.
Yes.
Yeah.
But even with other kind of infection, we use it for superficial and give a good result.
Thank you.
Okay, thank you. At the end of this discussion, I want to thank all attendants, and I thank again Dr. Muhammad Qahtani, Dr. Marwan Nazraouni, and congratulations for this perfect organization and success of this conference. And the floor for the next session, please. Thank you.
Thank you so much. Here we end our session 4. Thank you so much, Dr. Sharif. I thank you from bottom of my heart. Now, may I please request to call upon Dr. Tariq Al-Manofi. May I please request to call upon Dr. Tariq Al-Manofi. Okay, due to some reasons, Mr. Tariq is not available. Dr. Tariq is not available. May I please request Dr. Khalid Nover to join us? Thank you so much, Dr. Khalid, for joining us.
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank Professor Marwan, Professor Kahtani, and Professor Safwat Al-Husseini, who missed too much today. I have the honor to be part of this enormous meeting. Now I'll call Professor Joel Fish for zooming. He's ready? Not now? Absent? Unfortunately, he is not present with us today. I can introduce myself. Next speaker, myself. I am Khalid Nouir, completed MD degree at Shams University. Introduce myself. MD, School of Medicine, Egypt, senior consultant of plastic surgery, senior international speaker, fellowship trainer, senior lecturer at Aesthetic Academy of Egypt. Bismillah ar-Rahman ar-Rahim. My friends and colleagues. My talk is about complex reconstruction of wound lesions, essentials and advanced. As we all know, the normal wound healing is a complex series of reactions and interactions among cells and mediators that end by repairing the wound with a scar. It is an inevitable process. So, scar is a visible result of normal wound healing. What about variations in normal wound healing? Maybe in scarless healing, there is form due to minimal inflammatory phase, regeneration with the same type of tissues. Overhealing due to prolonged inflammation and overdeposition of ground matrix and collagen. Chronic wounds or arrested wound healing or abnormal wound healing. What is the chronic wound? Any wound that doesn't show a reduction in size by 10 to 15% per week or fail to heal within 2 to 3 months in spite of proper care. What is the cause? Almost due to internal factors, diabetes, ischemia, venous neuropathy, and malignancy. External factors may be in the form of irradiation from bodies, infections, repeated trauma, and surrounding fibrosis. The chronic wound is arrested in one of the wound healing stages. Usually, the inflammatory stage doesn't progress to the proliferative or maturation phase in a timely manner. These chronic wounds tending into papillary dermis or deeper will form a permanent scar. Once a scar, always a scar. With local complications, these complications may be in the form of scars and contractures, hypertrophic ones, malignant chains, keloids, also may be in the form of hyperpigmentation, ulceration, and alopecia. The focus of my presentation is how to manage some of these local complications. Clinical cases. This is a case of chronic wound affecting the upper third of the tibia, managed by aggressive debridement with local flap and grafting. Next case, post-traumatic chronic wound affecting the medial side of the left foot, managed by medial plantar flap with grafting. Next one, post-traumatic chronic ulceration with ankle plantar flexion, managed by tendon Achilles release and the grafting to elongate the tendon, local flap, split grafting with early physiotherapy, before and after. This is the case of post-burn ulcers with contracted elbow managed by grafting and physiotherapy. Next one, the case of keloid managed by local excision with immediate post-operative local radiotherapy with others conservative management to avoid recurrence. The case of basal cell carcinoma, lateral aspect of the nose, managed by local forehead flap based on supratrochlear vessels with intact lacrimal duct. You must cannulate the lacrimal duct before your surgical interference. Post-rectilical burn with chronic ulcers affecting the heel, managed by aggressive debridement with full thickness graft and nanofat grafting. The case of chronic ulcer due to basal cell carcinoma, excision with safety margin around and depth was done. Reconstruction by local flaps, before and after. The case of fourth degree burn affecting the dorsum of the foot with severe contraction and dorsiflexion, managed by tendon release and grafting with correction of dorsiflexion. This is the case of chronic ulcer due to basal cell carcinoma. Excision with safety margin all around and depth was done. Reconstruction of this large defect by a cheek advancement flap with nasolabial flap, no lower lid ectropion, and the scar is within the nasolabial line. The case of post-burn ulceration followed by hypertrophic scar complicated by severe elbow contraction, managed by local tissue expansion with serial excisions. Post-burn ulceration complicated by contracted axilla and the elbow with medial deviation of the hand, managed by local tissue expansions, with serial excisions and the early physiotherapy. Recurrent chronic ulcerations over medial side of the tibia, managed by segmental hemisoleal flap with grafting. Here, post-burn hypertrophic scar with neck contraction, managed by only 1Z blast is enough here. Why? The middle limb is within the lower, spotting with the lower neck crease. The lower limb is hidden by clothes. And the upper limb is pushed back to be out the field of vision. Post-burn, columnar tip and nasal septal complete destruction of the cartilaginous part of the septum, managed by bifurcated skin flap and distally-based mucosal flap sandwiched on conchal graft. Late post-operative, good nasal tip, good nostrils, columella, with preservation and correction of C-curve of the ala, before and after. Post-burn ulcerations complicated by contractures of fingers, managed by multiple release incisions and grafting with microball blasters. before and after, please, early physiotherapy is mandatory in these cases to avoid recurrence and contraction again. This is a case of post-traumatic chronic wound of the lower limb, complicated by contraction and with functional and cosmetic disabilities in the form of scarring. No lower limb muscle or orbicularis is absent here. Management steps. Firstly, you must know and good muscles in this area, mainly orbicularis oris muscle, depressors, and militalis. Started by marking the areas to be dissected. Dissection with excision of the deformed areas. And keeping the rest of any muscles here. After local excision of the scar and deformed skin, creation of myocutaneous flap, followed by opening the mucosal layer completely, the gum itself. Creation of mucosal flaps, adjustment of skin flaps firstly, advancement of mucosal flap till above the commissure. From the rest of orbicularis muscle and of upper lip. Closure of skin flaps with rest of muscles. Here, adjustment of the flap muscle with mucosa. Creation of dry and wet vermilion before closure. For also adjustment. Closure of all flaps. Final closure with formation of dry and wet vermilion after excision of excess mucosal layer. Immediate post-operative, in which myomucosal flap intersect distally with mentolabial skin flap and fibers, other fibers from mentalis, depressors, and elevators. Early post-operative view, late post-operative view with dry and wet vermilion locto-mental line and mental groove, white and red line. Paired over for and restoration of the normal lip function. In conclusion, the ultimate goal of all wound team members is to heal the patient's wound with least scarring and the maximum functional and cosmetic outcome. There is no known way at present to remove scar completely without trace. Scar may improve with the passage of time by maturation, but will never completely disappear. Once a scar, always a scar. Thank you for your attention. We have to move next speaker, Dr. Joel Fish. Is ready now? Ready? You can start. Dr. Joel, you can start.
Okay, can you hear me? And I just need a little indication that I guess people are seeing my slides, which I hope you are. And so thank you for
Your
inviting me.
presentation is not found.
Okay,
Share
just,
your
give me-
presentation, please.
Yes, just give me a second. Can you see my presentation?
Yes, you can start. Yes.
Okay, thank you. Well, thank you for inviting me to this conference. I'm going to talk to you this morning, which is this morning for me and this afternoon for you, about some of the innovative aspects of pediatric burn care that guide us towards the future. This is the view from my desk where I sit at the moment. For those of you that are not familiar with me, I spent more than 14 years as an adult burn surgeon looking after adults in a burn critical care unit with complex wounds and various reconstructions. And then around 12 years ago, I switched my practice to the Hospital for Sick Children in Toronto, where I provide pediatric burn care as a sole specialist. I work along with Dr. Goose, who is there and has provided some, I'm sure, informative talks at the conference. The only thing that I ask you is that you make sure that you send him home. As I look out my window and I see this great pile of snow, and I know that he's been posting pictures of himself in the sun, I just want to make sure that he returns back to the country. There are people in that audience for sure who have had connections with us in the past. I'm not going to name you, but I just want to say thank you. And I wish I were there seeing you in person. So I'd like you to just look at this slide for a moment, at this gentleman hanging upside down, enjoying himself. We'll come back to this at the end. And the question is, well, I guess the first question is, why would I even bother putting this in the talk? But the other question is, what does this have to do about a picture of better burn care? And I will get back to that. I'm here today to talk to you about a problem which is seen all over the world, and that is this issue. This is a 22-month-old child who was in the kitchen, and accidentally their parent turned around. They were unaware that they were there, and a hot cup of freshly boiled tea was spilled over their face, the ear, the upper chest, and the back. And I know that we see at our hospital 450 new acute burn patients a year. There are 1 to 2 every single day that come into the hospital. So it's a busy service. And what we see at our place is the same all over the world. In this talk, I'm covering the topic of the future in pediatric burn care from us. This is my own personal thoughts. None of these subjects, I have a 10-minute talk, none of them are complete in the sense that I'm going to dive into them deeply. And I'm really focusing on some of the science that you may or may not have touched on and some of the technology available. And I kind of use this to guide me through this talk. The first thing I want to start off with is actually a good way to begin this talk, especially since our last speaker who ended talking about scarring. And the holy grail of plastic surgery is contained within this article, which was published in Science last year, about the secret of healing without scars. And the science in this area is where the body works as a bioreactor and encourages skin to do basically what it was trained to do already in fetal development. And we know now that as you go through fetal scarring from the very early to late gestation, that the skin itself still possesses some regenerative capabilities. And it is this concept in science that people have still working very hard to get past where we are as burn surgeons at the moment, where it is an evolutionary advantage for wounds to repair themselves as opposed to regenerate. But irrespective of the kinds of surgeries we do and as good as we think we are, burn skin is still basically it goes through the inflammatory cascade as opposed to a regenerative cascade. And we know that if we can get something healed within 2 to 3 weeks for those wounds, that it will be an advantage. And this is something that is an advantage. Speed is survival, which is why we were created this way. So this concept of regeneration versus repair is something that I do follow, and as others should. And really one of the world's experts in this area is Michael Longacre, which is a name for students in the audience that may not be as familiar. And he has been publishing in this area for a long time. And in 2019, just before the pandemic, he, in a public address, talked about the fact that he feels that within the next 5 to 7 years, there are parts of the regeneration pathway that are going to be clinically viable to the point that we are going to be able to block things or turn things on in such a way that it will change the way that we do things. And this is really within our grasp, and the future really is closer than you think. Here is a group from the Middle East. This is a multinational group of people who have actually shown us, and the purpose of this slide is to diagrammatically tell you that if you look at the hair follicles, there are latent potential of the dermal fibroblasts during wound healing, which allow the skin to heal in a regenerative way as opposed to an inflammatory way. This group, as well as others in the world, are working very hard in this area. I am blessed that there is a gentleman in Canada. His name is Jeff Bernaski, and he is at the University of Calgary. For those of you that have visited Canada, a lot of people come to train. They train in Montreal and Toronto where it's cold, but it's nothing compared to what you'll get if you go to Calgary. I just want to tell you that he and we are involved in a group of research, and this is really his work, where he has been able to show that in the hair follicle, these dermal stem cells make minor contributions to the neogenesis of new skin, the neogenesis of hair follicles, and also of some of the collagen-producing cells, the fibroblasts. And the last part of this slide, without going into great detail, is that there are some well-known substances, including retinoic acid, which is something familiar to plastic surgeons, that actually control this regenerative competence. And there are more than a few labs now that are working on this, not just that they are looking at the mechanism, but real practical solutions. So I wanted to bring to this group that the future is not that far away. We have been following this story for 20 years in the plastic surgery literature, and it is now finally coming to a point where we are going to see something. What we do as burn surgeons with tangential excision is really what I would call a very crude approximation. And really, every time we go to surgery in the pediatric or the adult world, we commit what is called the perfect crime. Because we say the wound won't heal and we excise the tissue and we throw it away, we've created really what I call the perfect crime. And this concept of enzymatic debridement, as opposed to tangential surgical debridement, something that has been around for a long time. And there have been some advents in this area. And it's an idea that I think really requires looking at again. This is what we do with surgical debridement, right? We make a cut, we look for pearly white dermis, pale yellow fat, and patent vessels. There are various ways that this is done in different parts of the world, but we know histologically, if you look at a skull burn, it actually does this. So this surgical approach is really crude relative to what is going on. And you can go through and look at groups who use the enzymatic agents. They are not yet perfect for children. They're painful, they take time, but there now is technology that has been added to these agents, which is now allowing us to cleave off burn tissue in such an accurate manner as you see in this photograph, that I believe within the next few years, we are going to see a resurgence of this technology, which has been around for many, many years, but has never really caught on. One of the new things that is out there, and I am by no means an expert in this area, is the concept of electrospinning. And I just want to tell you But if you take a polymer in with a solvent, so you put it into a liquid form and you create these electrospun fibers, you can create different kinds of gels and scaffolds and ways of delivering cell in a nano level that has worked its way into the burn world and into plastic surgery in such a way that this technology has more than just a little bit of promise. And the things that are now available, they have a completely unique characteristics. And I just want to show you one example. So this is just an electron micrograph that shows you these electrospun, and they're electrospun materials. You can put just about anything in there. And there are many materials that we know already encourage wound healing. But there are two really important characteristics. This slide over here, which shows you the fiber diameter that you can measure, we know already that in the 150 to 200 nanometer range, this is where things such as Integra artificial skin and other kinds of dermal matrices impart their really positive effect. And you have such control over the spinning of these fibers that you can create surfaces now that mimic exactly the types of things that the human body requires. This photograph, I want you to this slide, I want you to really just look at this. This is a fiber, and here they're showing you that there's a core in here. You can add cells, you can add hyaluronic acid, you can add zinc oxide, which is toxic to cells. So you can add antimicrobials in these fibers, you can add live cells in these fibers. So not only is this a delivery system, and electrospinning is cheap. So unlike other forms of technology that have come and gone with the various kinds of dressings that gets applied, they tend to be very expensive and they tend not to hang around. But the electrospinning is new, and it is something that is really finding its way into our pockets. There's a group in here, you can see this is a large group of people who've worked on this, and they have taken these electrospun wound care dressings, filled them with zinc oxide, which is toxic to bacterial cell walls, and other kinds of substances, and they are highly efficacious. They work way better than the current dressings that we have. And this is new, and this is one of those examples where I believe the future is here. One of the things that I'm sure may or may not have been talked about in this conference is the concept of burn wound depth and why this is important for the future. In the scald burns, and particularly in children, as we wait for them to declare themselves and tell us what exactly we need to do, whether they're just going to scar and we're going to treat, or we're going to treat them with surgery, we need a way of knowing what is alive, in particular the basement membrane. We need to know if the cells that are there are working normally, and we need to be able to measure and control for the inflammation before we do surgery or just treat them in a conservative manner. I've had worked in this area for around 10 years, so this is an area that I follow. And this is an old slide. This is a slide of the care of burns over the decades. And when we introduced burn units and early surgery, tangential debridement in the 70s and 80s as this caught on, this line is the lethal dose of the burn in which 50% of people would die. The last two items that are left that are going to make an inflection in this curve and bring it so that the ultimate burn sizes are much closer to 80 or 90%, where you get 50% death rates. One of those issues is burn depth. So the person that sorts this out will make another difference in this curve. And the only other thing is our understanding and ability to diagnose smoke inhalation injury. This is a scientist that I have worked with. She has graduated from our program, who has taken technology and put it in a device called the Mimosa, which has been able to predict with great accuracy the treatment and the care of diabetic wounds. And she uses this concept of near infrared light. And there are other devices such as this, which have crept their way into the world. Burns and the use of laser Doppler technology. I do not need to come to a conference like this to talk about laser Doppler technology. We have this. And we use this as part of our review of the burn wounds. The technology itself is well proven and has been well developed, okay? This is just an example. It's an example of a child coming in. There are some deep areas, some superficial areas, some areas that are indeterminate. And you can map these out by color. And we know the science is out there that it is better than the naked eye. And even though there are, I'm sure, are practitioners in the audience who say, I've been doing this work for 20 years and I know exactly what's deep and what's not, we know that if you put it to a test, it's way better than we are, even though we don't like to admit this. But this technology, it's a great tool. The science is right. It's quick. There's a device that is designed specifically for pediatrics, which is much smaller. It works well, better than the naked eye with supportive research, but we tend not to use it. And I'm going to talk about that. We have a tool that we have just introduced for, it was used for chronic wounds and it's developed in Toronto, and you will see us starting to publish some work on this device called the Moleculite. It is basically an iPhone that is embedded in a circuit with a camera, and it's a special camera that looks at, with an optical filter, where it shines light of a very particular wavelength, and it allows you to see in real time clinically relevant levels of bacteria, up to 23 different species, in particular Staph aureus, Streptococcus, Pseudomonas, and the visualization of those bacteria are specific and clinically relevant. So it works, it's quite simple. It has a standard wavelength of light. It has a filter that allows you to detect things. The work that was done on this clinically to show that it works went on over 10 years. I'm not going to bore you with it, and the filters allow you to observe the bacteria. It is, I want to stress, it is not just a camera that tells you that bacteria are there. It will only detect significant levels of 10 to the 4, and that's what makes it so special. Many species of bacteria, it does not detect yeast. It has the ability to detect Staphylococcus aureus deep in the tissues, 2 to 4 millimeters, and there is a bit of a learning curve with this. This is just one clinical photograph. This is a axilla, this is a wound that had broken down, and although this wound and this tissue that is nearby looks like it's normal healed tissue, you can actually visualize Staphylococcus aureus that is deep and embedded in these tissues and requires removal before you do any kind of surgical flap or anything. So why am I telling you about this? Well, we now have a tool that allows you to clean a wound, both surgically or just through standard techniques of cleaning, and to visualize it in real time and tell you what is there. It allows you to focus your debridement in areas that are needed. One of the things about burned wounds and burned wound sepsis is when we take a swab and we sample a burn wound, say an entire child's back, you are depending on the fact that that specific area is positive, whereas this device allows you to sample exactly where you think the problem is, and based on both clinical and in real time seeing where the bacteria are. You can document this objectively, and then it also will guide your antimicrobial stewardship. This has been published. There's some preliminary work that was published. This is one of the last meetings that I attended in person. So what is wrong with us? And what is it about all this technology that I'm talking about? The first thing is it takes a lot of time. We run a very busy service, and honestly, unless there's more than one person there during our dressing changes, well, we sedate all the children for their dressing changes. It's almost impossible to sit there turning on and off all these devices. It's almost like you need to hire a whole separate human being just to get the information. And some people feel that these results are just confirmatory, even though we know that the science points us in the right
Professor
direction.
John, please for
Yes.
time.
I'm sorry?
Time.
Yes. And so the future with this technology is the fact that this diagram, if you look at this, picture these all as different devices in your home which you plug in the wall and all work. We now know that there are technologies that exist in the world that have the ability to stitch together all these programs so that they are literally instantaneously available to you. And this will be the next step that is going to allow us to incorporate these in the future. The other thing that I want to let you know about is that in order for us to reach the future, my personal belief is that we need to have standards in the care of pediatric burn patients. We are a verified burn center, and the thing about verification process is that it forces you to review what you do in a critical way, and it makes things better for the patient. And my wish and hope for the future is that places all over the world will eventually see this as an important way to the future, to ensure that they have clinical practice guidelines as we have, and they use these clinical practice guidelines to guide them so that everyone expects what to do, and that when things go wrong, you know where your starting point is, and so that it's not just a random system of care. I'm going to end this talk by telling you that the future is now with the use of skin equivalents. There's a group in Zurich which published this article last year of a child with a massive burn in the UK where they used a true skin equivalent. We repeated this last year and have published this article about using an advanced skin replacement technology. And in this case, where the future is now, we have a group in a laboratory in Canada that produces a full epidermis and dermis of the skin. And this is an 86% full thickness burn child that came to us. Dr. Goose will have talked to you about the use of biodegradable temporary matrix. We covered his entire back, shoulders, and buttocks with this. And as part of his care, this was left in place for weeks and weeks, more than 2 months, until we had grown enough skin in the lab. And we placed this on his back. There's an autograft in the center because this was released as part of a research trial. And here he is 4.5 weeks post-grafting, 3 months post-grafting, 11 months post-injury, and 1.5 years later as he comes back into our unit. And this skin equivalent is part of the reason why he is alive. So I started with this photograph of this gentleman hanging upside down, hopefully enjoying himself, where he has combined skydiving, windsurfing, and surfing all to come forward to the future to do something that is new, even though all of these things are very well recognized. And I want to use that image to end my talk with this comment, that it is my feeling the future of pediatric burn care lies in understanding the science of regeneration, a multi-user platform of diagnostic technology, and the use of advanced wound care products, where all of these things are things that we know about will finally come together to help us stabilize burn wounds and control inflammation and drive us towards the future. And it's not going to be a jump that is going to get us there, but merely a shift in all these things that we know. And just like him, where he's now hanging in the sky happily, my belief is that these things over the next certainly 3 to 5 years are going to make a major difference for all of us. Thank you for inviting me to this conference and allowing me to share the podium.
Thank you so much, Professor Joel, for this excellent illustrative presentation. Before going him, you can ask the floor. You can ask him. It's open for discussion for Professor Joel before going. Any question for him? Thank you, Professor Joel. Next speaker, we have to move to him. Professor Beritha Musayan, the zone presentation is present. Who is live now? Professor Beritha, you can start now.
Hi there, thank you. Can you hear me?
Yes, saying you, but share your presentation. Saying you very well. You can share your presentation now.
Can you see the presentation now?
Yes, start.
Oh, excellent, thank you.
Thanks. You can start now. Go ahead.
Greetings all, I'm Preeta Muthaya. I'm a consultant burn surgeon in Pinderfields Burn Centre in the UK, with a regional centre for Yorkshire and the north of the country. And I'd like to thank the organizers for inviting me to share with you all our experiences of using enzymatic burn debridement. I have no conflict of interest to declare. So enzymatic burn debridement has been around, and as Dr. Fish mentioned earlier, there were various trials in the 90s and 2000s using debridase and debrase. In 2014, there was this big publication by Professor Rosenberg presenting the results of a multi-center trial carried out in 13 countries in Europe. They used a bromelain-based enzymatic debridement mixer called Nexobrid, and in the study, which was carried out in patients ranging from age 4 to older groups, they found that Nexobrid significantly reduces the time from injury to complete debridement, the need for surgery, need for autografting, and the area of burn that is excised. So what is Nexobrid? This is mainly derived from pineapple stem, and the active ingredient is bromelain. There is a powder component, which is the active component containing the enzyme, and there's a carrier gel. The two separate constituents are mixed together and they're applied on burn wounds, which are pre-soaked for up to 2 hours, as the burn wound needs to be moist. The enzyme is applied, and following a 4-hour application period, it is removed, followed by wet to dry dressing. What does it do? It selectively debrides only heat coagulated protein. So if you look at the slide, the pictures on the left show conventional tangential excision, where one excises layer by layer down to a bed which has vital healthy tissue uniformly. Now, by doing so, we end up taking away tissue that is alive, and Nexobrid selectively takes away only what is dead. So this results in more dermis preserved. So dermal preservation would imply that the wound takes a shorter time to healing, better scar quality, and there is reduced blood loss. They have also demonstrated reduced operating theater time and sessions. I'd like to share our experience in using Nexobrid from 2016 onwards, and we've used it in 74 patients so far. Now, much of the experience around use of Nexobrid has been consolidated in the second European consensus document published by Hirsch in the Burns Journal 2 years ago. They brought together surgeons from 12 European centers with experience of treating over 1,200 patients. The main indications for Nexobrid are flame burns, which are mid to deep dermal. In full thickness leathery burns, there is no dermis to be preserved, so i.e. there is no point in carrying out any technique that is aimed at dermal preservation. Studies have also shown that it is not as effective in scald burns, especially because the enzyme has been shown to act better in collagen that has been denatured by high temperature wounds. So scalds are traditionally caused by wounds by lower temperatures, and therefore doesn't act as well in scalds. Timing enzyme can be applied immediately after a burn or early within the first 72 hours or later. It is especially useful in special areas such as hands, feet, and face, where dermal preservation is vital. However, the enzyme debridement is quite painful, and pain management is key to having a successful outcome. So we started in 2016, and year one, we learned a few things. The first patient we used it on, it was an 8-day-old burn, so something on the longer, sort of delayed enzyme, quite delayed for enzymatic debridement. And this was a deep dermal wound. There was quite a lot of dermal preservation, and this wound healed spontaneously in 3 weeks. The second was a larger burn, 17% burn in an elderly male following a house fire. The enzyme was applied to both upper limbs, but in 2 sittings, as this man had regional blocks. There was excellent dermal preservation, but the wounds were quite painful, and he required small areas of autografting over the dorsum of the hand, less than 2 by 2 centimeters square. And as you can see, he went on to heal quite well and had a very good range of movements. The scar following enzymatic debridement can look quite hyperemic initially, but in the long term, after 2 years, settled really well. So we primarily focused during our first year on small burns, hand burns, using regional block. And this was because our main challenge was pain when we used it in any larger size wounds, over 10%. We postulated that exposed dermis can be painful because Nexobrid preserves all this dermis, but the exposed wound is extremely painful. And what do you use to cover it? And we still hadn't identified what the ideal dressing was. So second year, we shifted and we started using it in patients who were intubated in intensive care. The first was a 52-year-old male who had a 30% flame burn following a house fire, and he had severe inhalation injury. Nexobrid was applied on day 2, and there was good dermal preservation. We temporized the wound by covering the dermis using xenograft on day 3. All this was done in ICU as he had very severe inhalation injury, and his respiratory parameters is quite unstable. 10% of the wounds healed and 15% needed a split skin graft, but this was after he was stepped down to the ward and he was much more stable. After the use of this in the first few intensive care patients, we started to notice a response when the enzyme is applied in resuscitation level burn injuries. So in the UK, it is any burn over 15% of the resuscitated, especially if the patients are still being fluid resuscitated and they are hypovolemic. The pain response that the enzyme produces causes hypotension and tachycardia, and this can often mask the underlying hypotension. To help with the pain, the patients have increasing doses of opiates leading to vasodilation. And in 4 hours' time, when the enzyme is taken off and the pain stimulus goes away, patients actually become quite unwell. So we recognized that and we worked around it. So we made sure that patients are adequately fluid replenished and they get adequate fluids. And we expect that they will be a bit unstable and we expectantly manage this. And once we started doing this, we found that this wasn't an issue anymore. Something else that in the year 2 we started to use was the introduction of a specific pain protocol, and this was published in the Burns Journal in 2020. This is just routinely identifying that patients with enzymatic debridement can have quite a lot of pain, and even in patients in intensive care, we start them on gabapentin, etc., quite early on. And all regional blocks for upper limbs are done in a way that we ensure these regional blocks are long-acting. And after this, the pain scores, which were initially 8 or 9, came down to 3 or 4. So the wounds were a lot more comfortable for patients to manage. So year 3, after we were comfortable with physiologically managing the patients for the larger burns, we started to look at various wound cover decisions. And we looked at various strategies to improve epithelialization. Keratinide suspension spray or RECELL was quite useful in some wounds, and we used it in combination with allograft, and we found wound healing to be better than expected. Now, this hasn't been formally published, and we are studying it, and we will be doing so soon. And team working was essential. The surgeon, the intensivist, and the nurses worked together very closely to get a good outcome for these patients. So what is our current practice? We mainly use in resuscitation level burns who are intubated. We focus on areas where dermal preservation is important, hands, feet, and face, and in other special situations. We do not use in completely full thickness burns that feel leathery to touch, and in larger burns in ward level patients who can potentially become quite unstable if they need intubation for pain relief. Also, NexoGrid is contraindicated, obviously, in people with pineapple allergy and latex allergy. Coming to patient selection, even if the burn wound looks deep, on palpation, if the wound is soft, then often there's dermal preservation, as is shown in this gentleman, where after application of enzyme to the abdomen, wounds that will look full thickness actually had significant dermal preservation. It is often used in our team as a multi-tool approach. So we use enzyme for certain areas and surgical excision to other areas. This young lady who suffered a flame burn had surgical tangential excision to obviously deep, full thickness, leathery eschars on her chest, but to her face and hands, we used the enzyme, and it all worked together, and she had a very good result for her hands and the face. Escharotomy with enzyme is useful, so in circumferential deep partial thickness burns with impending limb compromise, the enzyme can be used, and within 10 minutes, the limb starts to get noticeably softer. Now, whilst doing this, it is quite important to ensure that the limb is exposed and the senior person is around to actually make sure that the enzyme is doing what it needs to do. Following wound debridement, various dressings are used in our team. We use EpiProtect, which is a cellulose-based dressing. We have used BioBrain, Suprathel, and we went through a learning curve where we used a host of other dressings and tissue substitutes and autografts, as mentioned here. Basically, the decision to be made after debridement is there dermis, and is there good quality dermis? And also one has to take into account the physiological stability of the patient. If there is very healthy dermis in almost all areas in a very stable patient, the wound will heal no matter what cover you use. So we use cellulose dressings, we use xenografts, and even Mepital or silicone dressings for smaller burns. But the more exposure of reticular dermis or fat, then one would look at allograft or RECELL or even autografting the burn wound if there is large areas of reticular dermis. Sometimes we autograft on day 3 or later, or often we stabilize with an allograft and then apply autograft later if fat exposure, reticular dermis exposure is patchy. So these are some examples where this gentleman had the wounds dressed with silicone dressings alone, And this is spontaneous healing with a cellulose-based dressing, spontaneous healing with xenograft, spontaneous healing, so healing without use of allograft, without use of autograft, and the wound was covered with allograft, a cadaver skin, and RECELL, and the wound healed spontaneously. Now, when large areas of reticular dermis are exposed, as is seen in this wound, one would need to apply an autograft. If we often use Meeks grafting and we use various expansion ratios from 1 to 2, 1 to 3, 1 to 4, depending on the amount of dermis and the nature of the wound bed underneath. We found that if you graft too early, i.e. the day after burn debridement, often the graft doesn't take, and this has now been confirmed in a number of studies. And the reason for that is postulated to be presence of some debris in the dermal crevices. So we usually wait for 72 hours before we autograft. And in large areas of exposed fat or thrombosed vessels, then autograft is the only option. So if there is exposed fat, then this wound will only heal if you apply a skin, autograft skin. So the key to success is teamwork, learning from mistakes, and also, especially in the earlier phases, regular review of the burn wound by a surgeon or a consultant who's experienced in enzymatic debridement. We published the results of our experience in use in critically ill patients in Burns Journal, where we devised an algorithm on how any burn greater than 15% is assessed initially. And there are 2 steps in the decision-making process. One is initially, is the patient suitable for Nexobrid? And is he suitable for combined surgery, combined treatment with enzyme and surgery? And then to make an estimate on when to use the enzyme, where to use, when to use surgery, and what areas and sites to do first. We usually debride up to 20% enzymatically in one go. And we have seldom debrided more than that, unless it's a circumferential limb wound and we're doing it in lieu of eschorotomies. Following debridement, we then again make an assessment on cover. Will this wound heal spontaneously or will it need autografting? And again, what areas? And we make a treatment plan and then we stick to it. So in use of burns, in burns over 15% EPSA, we've used it in a total of 43 patients. There's a number of advantages in addition to dermal preservation. We found that it is enzymatically debrided patients had time to complete debridement much earlier than surgical debridement because we were able to start this as soon as the patient arrived, once fluid resuscitation was commenced. There have been some anecdotal reports of coagulopathy, and we have looked at this extensively in our patients matched for surgical enzymatic debridement, and this has not been validated. There was no difference in enzymatic debridement and coagulation abnormalities. Also, when we looked at theater trips versus surgical and enzymatic debridement, we found that enzymatically debrided patients had fewer intensive care stays, fewer number of days in ICU, and this is despite the incidence of inhalation injury being twice as much in the enzymatically debrided group compared to the surgical group. So what have we learned? This is an operation, so manage as such and pay a lot of attention to pain relief. Manage them as you would do a surgical patient. Also, it is important to have a plan on what to do after debridement. It's important to remember that this is just another tool in the debridement box. It is not a replacement for surgery, but it is just another tool that can be used alongside surgery.
Dr. Beriza, time out, please, yeah, short.
Yeah, thank you. Just one more slide. So enzymatically debrided wound, it works well when used correctly as it spares dermis. It may avoid eschorotomy. It can be used alongside surgery, and it is very beneficial in ICU patients. Thank you.
Thank you so much, Professor Beriza, for this excellent illustrated presentation. Shall we move to next speaker, Professor Wael Saar from Egypt? He's ready for zooming now. Can I start? Not with us now?
You see me now? No? Hello?
دكتور وائل احنا
You
سامعينك.
hear me?
Yes, ready, yes.
Thank you very
You
much,
can
Dr.
start.
Khalid.
Professor Wael, you can start.
Thank you very much. It's my honor to speak to you again this magnificent day. I have to thank Dr. Marwan and Dr. Mohammed Qahtani, Dr. Safwat Al-Husseini, and the whole Chairman. Mr. Chairman, I have to start with the tissue expansion of post-burn alopecia, secrets of success. The scalp is the second most visible part of the human anatomy after the face. Post-burn alopecia is a common condition requiring treatment of large areas of defects in the skin and soft tissue, which poses a real challenge to the reconstructive surgeon. Cicatricial alopecia is a form of hair loss that causes both cosmetic and psychological concerns, this forcing the patients to conceal the zones of alopecia with hats, hair pieces, and wigs. The reconstructive option is a difficult task for the surgical team in terms of both outcome of surgery and patient satisfaction. Alopecia management, many treatment alternatives such as reduction techniques, hair grafting, and skin expansion techniques with local or free flaps have been described for cicatricial alopecia. The conventional methods of rotational flaps, serial excision, microvascular free flaps, follicular unit transplantation have many drawbacks, including lengthy hospital stays, flap necrosis, and inability to cover major scalp defects. Scalp defects more than 3 to 5 centimeters, which are usually challenging to correct because of the tensile strength of the wound. Closure, as well as due to the phenomenon of stretch back, which occurs subsequently after excision. Anatomical concepts, these are the layers of the scalp which we put the expander below the gallia. Tissue expansion is a valuable addition to the armamentarium of hair restoration surgery. The concept, tissue expansion utilizes the viscoelastic properties of the skin to provide autologous soft tissue coverage with a skin that is near identical color, texture, and hair-bearing potential, and minimizes the donor cycle. The tissue expansion provides a natural hair-bearing skin for scalp reconstruction with a near-normal hair density. Currently, it is believed that an alopecia area involving 50% or more of the total scalp area can be repaired using tissue expansion. The mechanisms of tissue expansion, 70% of tissue gain is due to stretch and 30% due to biological creep. Tissue subjected to constant strain then relaxes, less force is required to keep it stretched. It's known as stress relaxation. For example, a wound which is under tension in intraoperatively but relaxed at outpatient follow-up is an example of stress relaxation. Mechanism of tissue creep, distribution of elastin fibers, the realignment of collagen, fluid displacement, migration of local tissue. Biological effects of tissue expansion, thickness of the epidermis is increased, thinning of the dermis, alignment of the collagen fibrils, improved vascularity, bone deformation, and periosteal action. There is a capsule which is formed, the inner layer of the capsule synovial-like lining, the central layer, and the transitional layer, loose collagen, the outer layer, vasculature, and collagen. Vascularity of the expanded skin. Vascularity of the expanded skin is superior to non-expanded controls. Flap length survival is equivalent or better than that achieved with conventional delay techniques. These are the different types of expanders. These are the eternal expanders we are talking about. Expandable saline-filled silicone bags. Location of the port, either it is a remote port connected to the reservoir with a tube, or an integrated port. Maybe the port is integrated part of the expander. The expander has a base and surface. The base, which is the stable base, the most common, which is rigid, permits unidirectional expansion to the outside. The soft base allows expansion in all directions. The surface of the expander is smooth or textured, allowing ingrowth of capsule into device. But now we use mostly the smooth one. It may be permanent expander used for breast reconstruction, which is the expander prosthesis, which has two compartments, outer compartment or inner compartment. These are other examples of tissue extenders instead of expanders. Another example of extenders and also the Brava device, which extend the tissues in the breast. This is out of the scope. There are also the self-inflating expanders, which contain a hypertonic compound that gradually fill out through osmosis, but we cannot control the volume which is expanding. These are the shapes of our expanders talking about, either rectangular, oval, circular, or semicircular, or crescentic. It depends on location. In the rectangular expander is well suited for to long and narrow extremities, circular shape in the breast, and crescent in the scalp. The amount of tissue available for advancement flap is equal to the circumference minus the base of the width of the expander. Contraindication for expander use, relative contraindications, previous or anticipated radiation therapy, psychiatric patient, near an open wound. Absolute contraindication, near malignancy, undergraft skin grafts, open infection, already tight tissue. Disadvantages, multiple operations, at least 2 are required, 2 for each stage, I mean. Reconstruction is delayed until expansion is complete. Multiple outpatient visits are required. A temporary dramatic aesthetic deformity exists during expansion process. Risk and complications, pain, exposure, or infection. Complications, minor complications like pain, scar widening, dog ears, transient neuropraxia, seroma, and hematomas. Major complication, exposure of the implant, infection, hematoma, expander deflation, mechanical deflation, I mean, skin ischemia, and necrosis of the flap expanded. Risk factors associated with higher complication rates in the children, especially under the age of 7. When we use the extremities lower than the scalp, burn reconstruction, because the skin is not that viable, irradiated field. These are the courtesy of Dr. Tayyab. Tips for success, how we can increase our chance of success. In fact, success with the expansion process usually depends on size and location of the lesions, proper selection of tissue expanders and donor area, effective expansion, and appropriate transplanting of the expanded hair-bearing scalp. I put here some of my experience in the use of expanders, especially in post-burn patients. The first tip is planning. You have to use first the decision of and selection of the flap should be made before the tissue expander, not the reverse, in order to avoid unnecessary tissue loss. So we decide which flap we are going to use. Infiltration. Intraoperatively, we infiltrate subgallian injection, saline only for hydrosection, or sometimes we increase saline and adrenaline 1 to 100,000. The incision. The use of a small remote incision for tissue expander access. Remote incisions permit the approximation of healthy tissue edges that may offer superior soft tissue healing. Pocket creation. The section of an appropriately sized soft tissue pocket. The pocket should be larger than the expander base size and sited on the base that resists mechanical deformation to direct the force of expansion. To be careful not to put the expander reverse upside down. So the pocket is one of our important items. You will be lucky if you have this instrument, the utilization of illuminated lighted retractor to facilitate the hemostasis and dissection. We have different sizes for each company. The size comes from base, length, width, and height. Select largest expander size available to fit within the soft tissue pocket. So we start to measure the part which will be expanded. This base, I'm going to the chart of the company. I want, for example, 10 by 6. The volume first. You have to start by the base first. Advice that the base of the tissue expander should be at least equal to the length of the defect to be covered to ensure adequate soft tissue expansion for resurfacing tension-free closure. This is for one stage. Sometimes you need more than one stage if you have a large alopecia area. These are the shapes of the expanders. Rectangular expanders provide greatest soft tissue surface area gain. And one of the studies showed that the rectangular tissue expanders provide a 30% increase in the surface area compared with 25 in rounded expanders. Different ports. We have different ports coming with the sometimes coming with the expander, and other companies sell it alone. We have some port tricks. For the port placement, when using an expander with a remote valve port system, side the port away from the tissue expander to avoid unintentional perforation of the expander, because as time goes and the expander enlarges, it will encroach or be near to the port. So you have to put it a little bit away, but close enough to avoid second incision. Also, the port pocket with the fixation of a suture if the risk of the port migration is high. You dissect for the port, then you take a suture around the tube to prevent migration or coming again back to near the implant or the expander. Port externalization may have a higher infection rate. Sometimes you may be obliged to make it an external port. Port sizes, we have small, intermediate, and large ports. If we're going to insert in the scalp or any superficial area, we can use the small one. But in the deep or fatty area, the small one may disappear. So you have to put the large one. Also, this is one of the tricks, to use more than one expander at a time, maybe 1 or 2 or 3. Multiple expanders, consider the use of multiple tissue expanders if you have tissues to take, because this cited either the side of the soft tissue defect in anatomically suitable area. The use of multiple expanders divides the volume of expansion required in a single area and reduces the overall duration of expansion. So you gain much more tissues in a less time. Such benefit must be balanced against the risk of infection with multiple expanders. Because if you have an infection in one of them, you may lose the whole expander if the pockets are open to each other. The plane of dissection, as we all know, is subgallial. Subgallial tissue is important. Plane is too important to protect the integrity of the hair follicles, so as not to lose hairs during expansion. Also, the vessels of the flap is above the galleon. It helps to preserve the blood supply. Handling the expander. We minimize the handling. So your nurse just open the expander and give it to you. Not too many, and the assistants, you take it the box of the expander and test it and put it immediately. Minimize the hands touching the expander. Testing the expander. You have to do mechanical testing of the expander. Try to inject and to make sure that it is not leaking from the tube or from the expander itself before insertion. Sometimes it comes destroyed, so you can exchange it. We have to use antibiotics, systemic and local. Systemic IV, and local you can inject a local antibiotic inside with a saline inside or around the expander. Drains. Place a closed system in suction drain within each tissue expander pocket to prevent hematoma and seroma formation. It minimizes dead space also, and when you inject it, drains should be sited adjacent to the flap pedicle and leading edge. Continuous infiltration of local anesthesia has been shown to reduce the pain. Layered closure. Close the skin in layers using absorbable deep dermal and staples or non-absorbable for the skin. During closure, there is a high chance of perforation of the expander. So you or your assistant should put something to protect the expander. A malleable retractor can be used to protect the tissue expander during closure of the deep dermal layer. Timing and overexpansion. Begin soft tissue expansion maybe 2 to 3 weeks after expander insertion to make sure that the skin wound have been healed. Expansion rate is dictated by the pain in the patient, and the blanching of the overlying skin. Overexpansion, sometimes we expand up to 2.5 the volume written on the expander box. This is a trial of endoscopic insertion in pediatric expansion. The second operation, expander removal and flap design. As we told you before, the flap was designed before. So we use either rotational flap, advancement flap, or transposition flap. Sometimes you use a flying wing design scalp flap to make sure that you are going to lose tissues. Multiple sessions for large alopecia area, which will not be treated by one session, you may put another expander after flap insertion, so you can do it in multiple stages. This is one of the debates. Adding galiotomies to subgaleal tissue expander insertion may also lessen the risk of
Professor
wild
Wael, please يعني time up now. Please يعني if you can
okay.
continue with short and conclusive.
Dr. Khaled, I had 15 minutes. Now I only 8 minutes. Okay. Okay. Clinical cases.
Can 2 minutes? Yes, 2 minutes.
Okay. Thank you. This is one of the.
Go ahead, Professor Wael. Go ahead.
Okay, thank you very much. And this is the flap after insertion and the removal of the alopecia area. This is our child with post-burn alopecia. This is the expander, and this is a very happy child with a good looking hair. This is the same child, my dear friend. This is one of our patients. Unluckily, she's mentally unstable, and this is one I decided to not to put because the compliance of the patient with the expander was not good. But I had 2 flaps on the right and on the left, and she's very happy now. This is our cute baby. And this is another case showing alopecia and we're making an anterior hairline. And this one with alopecia and going to swim in Alexandria. Massage tissue expansion takes the advantage of viscoelastic properties of the skin, specifically creep and stress relaxation. The epidermis is the only layer that thickens in response to tissue expansion. The other layers become thinner. Rectangular expanders give the most skin expansion of all shapes. The base of the expander should be 2.5 times the diameter of the defect to be covered. Thank you very much.
Thank you so much, Professor Wael, for this excellent presentation. You can ask him before going down. Any question for Professor Wael? Thanks again, Professor Wael.
Thank you, Mr. Chairman. Thank you very much.
Shall we move to next speaker, Professor Tariq El-Monofi? Is present now? No. Oh. Unfortunately, I'm not found or finished. We have to close the session. Now we have to close the session. Thank you so much, all the friends.
Thank you so much, Dr. Khaled. We now conclude our session 5, and my sincere apologies to inform you that we are skipping the coffee break and we are moving to session 6. May I please request to call upon Dr. Mohammad Al-Khatani to join the gathering. Thank you so much, Dr. Mohammed, for joining us.
Hello, this is the final session. We are proceeding the talk with Mrs. Khulud Yassin. She's a senior nurse at the burn unit in King Abdulaziz Medical City. She will talk about the nursing perspective in caring pediatric burn patients. We welcome Mrs. Khulud. She's around. Then we'll call Hazem. Next speaker, we have it on Zoom until we have Mrs. Khulud around in the lecture hall. Dr. Hazem Khalaf. Okay. Zoom, yeah.
Thank you very much. I hope you can hear me. I'll just share my presentation. Okay, thank you very much. We have been working with antimicrobial peptides for a few years now, and I would like to share with you our latest advances in this field by starting with a short background. Now, Elie Meshnikov was a great scientist and, of course, in the field of immunology, and his discovery of phagocytic cells was awarded the Nobel Prize in 1908. Besides his research in immunology, he was also conducting research in the field of microbiology. And he noticed that citizens in Eastern Europe, although they were generally poor, but they lived very long and healthy lives. And it was mainly due to their consumption of probiotics in products such as soured milk and yogurt. Unfortunately, this research field died out after the discovery of penicillin by Sir Alexander Fleming, and which is, of course, fortunate for us since penicillin saved many lives. And this was awarded the Nobel Prize in 1945. This encouraged researchers and pharma companies to search for these magical drugs, so-called antibiotics, and without paying attention really to what Sir Alexander Fleming was trying to tell us, which is that bacteria can easily develop resistance against antibiotics. And in the so-called golden age between 1935 and 1960, many antibiotic molecules were discovered. And soon after their introduction to the market, the resistance starts to develop. Pharmaceutical companies nowadays are not interested to develop new antibiotic molecules because they know for a fact that it's time-consuming and a very costly process. And as soon as it comes out to the market, the bacteria will develop resistance against it. And of course, medical doctors will be very restrictive in using these new antibiotics because we don't want bacteria to develop resistance against them as soon as they come out. Which leads us to that we are now facing a real challenge globally. And this challenge, in the future, it may lead to that a simple infection can actually be lethal. And we have to find alternatives on how to tackle this antimicrobial resistance problem in the world. One of these options is antimicrobial peptides. A subgroup of antimicrobial peptides is known as bacteriocides. They are derived from bacteria. There are a lot of antimicrobial peptides. Unfortunately, most of them are toxic. One of the products that has long been used as a food preservative is the Lysine, and it has an E number of 234. Another one is the human antimicrobial peptide called LL37. And of course, there are numerous synthetic peptides. We have mainly been working with antimicrobial peptides that are derived from bacteria, more specifically from Lactobacillus plantarum. And in the locus, the plantaricin locus, in the genome of Lactobacillus plantarum, we can find many different plantaricins or bacteriocins. We have been working with 3 of them: C8 alpha and beta, J and K, and E and F. These are so-called 2-peptide bacteriocins, so 2 separate peptides are required for full antimicrobial activity. I will focus mainly on PLNC8 alpha and beta. The alpha peptide is composed of 29 amino acids, and the beta sequence has 34 amino acids. And both of them form alpha helices as determined by NMR. Now, one characteristic of scientists is that although something is working wonderfully, we feel the urge to improve it even more. And this is the case with PLNC8 alpha and beta. You've heard my colleagues present some data, Daniel Ailia and Johan Juncker. We see wonderful results with antiracein alpha and beta. It's very potent against specifically gram-positive bacteria, and it can synergize with many different antibiotics. It shows basically no cytotoxicity on human cells, and it can counteract the cytotoxicity that is induced by the bacteria and also its inflammatory responses. We have previously shown that PLNC8 beta, the beta sequence, but not the alpha sequence, can actually permeabilize bacteria. And this encouraged us to try to use that as a basis to develop a new generation of antimicrobial peptides. And we generated a small peptide library, and we used two different strategies. The first strategy involved truncation. So we truncated the full-length PLNC8 alpha and beta, and we truncated using 16 amino acids throughout the entire sequence. The second strategy involved modification, so introduction of new amino acids to try to increase its activity. And it was based on by projecting the peptides in a helical wheel. All the peptides that are highlighted in boxes are the ones that had a positive score, which means that they potentially are antimicrobial peptides. And the ones that are highlighted in green are the ones that we synthesized and tested in biological systems. We show here we found two peptides that had antimicrobial activity. One of them was a truncated variant, and the other one was a modified variant. And these results were compared to the human peptide LF37. The truncated peptide, interestingly, it showed antimicrobial activity against both gram-positive bacteria and gram-negative bacteria, which is, of course, very interesting. So we proceeded with this variant, and we introduced further modifications to increase its activity. And we had different strategies here. The first strategy involved amidation of the C-terminal region and acetylation or pegylation of the N-terminal region. And the second strategy would, we would reverse this process. So basically, we would acetylate or pegylate the C-terminal region. We also considered cyclization of the peptide. In both of these strategies, we added another modification in which we replace amino acids to, for example, alter the net charge and thus its activity. And by doing that, we generated a new set of peptide library, and we tested them. Now, this is a rather busy table, but we'll try to go through it. The first part included, so we have full-length PLNC8 beta here, and when we truncate the peptide and acetylate the N-terminal region, we can enhance its antimicrobial activity because full-length peptide has no activity at all. If we elongate the fatty acid chain to 4 carbon atoms, the activity is improved even more. Elongation to 5 carbon atoms further enhance its activity against both gram-positive and gram-negative bacteria. If we synthesize this peptide using D enantiomers, it is still active. In fact, the activity was even more improved, specifically against gram-negative bacteria. And this is not a surprise because the amino acids are stable against proteolytic degradation. And this also indicates that the peptide does not bind to a specific receptor. It targets a general motif on the bacteria. In this sequence, we have 3 isoleucines, and we replaced all these 3 isoleucines with leucines. Interestingly, the peptide was still active. In fact, the activity was improved against gram-positive bacteria compared to the native one. And again, synthesizing this peptide using D enantiomers further enhanced its activity specifically against E. coli. The same blocks can be seen here with peptides that have a fatty acid chain composed of 6 carbon atoms, 7 carbon atoms. When we elongate the chain to 8 carbon atoms, we lose some of the activity against gram-negative bacteria. 10 carbon atoms, we start to lose the bactericidal activity against gram-positive bacteria. 15 carbon atoms, all the activity has disappeared. And pegylation did not enhance the antimicrobial activity of this peptide. We also show that the effect is rather rapid. As soon as we add the peptides to a bacterial suspension, the peptide will target bacteria, permeabilize their membranes, and the bacteria starts to fluoresce. Here we have a fluorescent dye that is called Cytox green. This dye cannot enter intact membranes. It can only migrate through damaged membranes. And so we see a direct effect here of the peptides that they do permeabilize the bacteria. Now, the safety was investigated using in vitro methods. First of all, hemolytic activity using human erythrocytes. And we can see here that the longer the fatty acid chain, the more hemolytic activity. And all the peptides that had the fatty acid chain with 7 carbon atoms or less was not that hemolytic. And so we had a window here of peptides that were active and showed no hemolytic activity. And we proceeded with these, tested them more specifically for their hemolytic activity, and also the leucine variants. And interestingly, we show here that when we substitute the isoleucines with leucines, this renders the peptides to be more hemolytic. The exact same trend is seen with the D peptides. However, C5, the peptides with fatty acid chain that has 5 carbon atoms, were not that hemolytic. And so now we have our lead compound, basically. So a peptide composed of 16 amino acids and with a fatty acid chain of 5 carbon atoms. We combined our peptide with antibiotics. The most important thing here is that we don't see any antagonistic activity, which is of course wonderful. We only see synergy or additive effects, and in combination with antibiotics that belong to different groups, target different proteins or moieties in the bacteria. And we expose the bacteria, both gram-positive and gram-negative, to the peptides using submit concentrations for a month, so 30 generations basically. And we don't see any signs of tolerance or possible resistance development. And this is, of course, important. What about real cytotoxicity and inflammation? Well, this experiment is kind of special because we have administered 3 doses of the peptides. So once every 4 hours for 24 hours. And the control cell, you can see the control cells, it's an entire mat of cells. They look nice and healthy. And with the peptides, we see more dead cells, especially in the concentration 40 micromolar. And a slight increase in cytotoxicity with the 40 micromolar. It can be discussed though, whether this is dependent on direct cytotoxicity or indirect. And by that, I mean the peptide maybe is inducing too much cell proliferation, and thus the cells die faster. This remains to be determined, and experiments are ongoing, of course. Besides that, we don't see any major effects on any of the inflammatory markers that we have investigated so far. Can the peptides counteract a bacterial infection? This was the aim and the question that we addressed in this experiment. After infection with Staph aureus, all the cells are dead. There are no signs of viable cells at all. And addition of the peptides, again, 3 doses, once every 4 hours for 24 hours, completely eliminated the bacteria in a dose-dependent manner, except for the concentration 2.5 micromolar. So both the cytotoxicity was decreased and the inflammatory responses that are induced by the bacteria in that case. And again, 40 micromolar seems to be a concentration that maybe is too high, at least when given in 3 doses. So this needs to be evaluated even more, of course, and again, experiments are ongoing, and hopefully we can. Now, to summarize this very brief presentation, we believe that we have developed a very unique and a very potent broad-spectrum antimicrobial peptide, and animal experiments are ongoing, and also in vitro, of course, as well as ex vivo experiments are planned and ongoing. This can be compared to antimicrobial peptides that are available in the market today. One of them is daptomycin. It is isolated from a bacteria that is called Streptomyces cercospores. It's a cyclic peptide with 13 amino acids and a carbon tail of 10 carbon atoms. Looks like this. It's only active against gram-positive bacteria and thus used primarily against infections that are caused by Staph aureus. The mechanism of action is that it binds to peptidoglycan in a calcium-dependent manner, aggregates, and forms pores that result in leakage of ions. And since it binds to peptidoglycan, it's not surprising that it's only active against gram-positive bacteria, because gram-negative bacteria are protected by an outer membrane, so it's not active against gram-negative bacteria at all, compared to our lipopeptide in this case. Special thanks to my dear friend and colleague, Robert Seligord. We have developed these peptides and validated their activity together. And of course, to our financial support from the Swedish Foundation for Strategic Research and the Knowledge Foundation. Thank you very much.
Thanks, Dr. Khalaf, for your research. And I will call for the next speaker, Dr. Mohammed Dessouky. Dr. Mohammed Dessouky will talk about something interesting in managing a practice as a surgeon. We have ideas and innovation, how to run a practice. Welcome, Dr. Mohammed.
Thank you, Dr. Qahtani and Dr. Zaroni for this invitation. I will start with a short video present to Dubai people who presented this world as the example of quality. Thank you, Dubai people, for making this city great. The title of my presentation is Be in Business. Consider being business an alarm or an invitation or a call to action. Because in our study, as in medical practice in general, we don't have any commercial or we don't have any commercial background. Next, please. I would like to remind you that we have a present to the attendance today, 1 month social branding. So please stay tuned at the end of the presentation. Next. Kiyosaki said one day, why is work for the seas and bees work for the government? Simply because our educational syllabus lacks the commercial syllabus. That's why we don't have as many entrepreneurs in the medical field or the healthcare field in general. Next, please. Let's see some of the most famous dropouts, college dropouts. We call them the C's. Steve Jobs is a college dropout, but he's a tech tycoon. And also Oprah Winfrey is a media tycoon. Those are the C's. Those are the failures in education. Next, please. Why we should be in business. Next. Business is a science like any other science in the world. Maybe the only science that affects everyone the whole of his entire life. Can we think together, what is the most important invention in history? Modern scientific management is the most important invention in history. Frankly speaking, under the right management, you do the right thing and succeed. Under the wrong management, you don't succeed. Some of the most famous management sensitive icons in the world. Let's see. Do you think that Dr. Zuhail was going to do what he did in Alexandria, not in Caltech, or Mo Salah was going to do it in Egypt, not in Liverpool? I don't think so. A more complicated situation, the same person, the same time, the same talent, under two different managements at the same time, his performance is completely different. Salah in Liverpool is different than Salah's performance with the Egyptian national team. People succeed when they are lucky to be in a professional management environment, whatever their industry. Dr. Zuhail in science, Mo Salah in sports, anybody in his practice. What is the future of healthcare? There is one destination of the future of healthcare. which is digital transformation. Digital transformation will control everything in healthcare. We used the stethoscope for hundreds of years with the same traditional functions. But later in the future, the stethoscope will serve with AI, with artificial intelligence, with creative functions, hundreds of creative functions. Maybe you will be sitting, putting your stethoscope on the patient, and your screen is giving you hundreds of results you never knew before. Healthcare students even may spend half of their learning time in the engineering section because the engineers are sitting in their labs and the medical students are sitting in the labs as well, but no one knows what each one needs from the other. The future will produce programmer healthcare professionals. Future will be the intersection between technology and science, and all this surrounding in 360 degrees the society. What is missing in healthcare industry? Healthcare professionals need business knowledge and soft skills. Soft skills is something not understood by everyone. What is the soft skills and what is the hard skills? Hard skills, what we learn in school and college, but soft skills, what we learn to succeed in our practice. This is a very simple difference. There are hundreds of soft skills. You should study and learn what you need for the success of your practice. Management functions. The most important management functions is business development, problem solving, and control. We will come in a minute for more details about problem solving. That is simply why healthcare professionals need to know about business. Planning, the most important management function. Nobody can live without a 3 to 5 years business and marketing plan. Feasibility. Before starting your project, you should know and understand the feasibility of the success of your project. Problem solving. One of the most incorrect understandings in the industry that some people are thinking that the manager should wait for problems to happen to solve it. But this is a very wrong thing, because the good manager should avoid problems before they happen, not waiting them to happen and solving them. Auditing. You should know where to put your checkpoints and milestones in your project. Marketing. Marketing helps you to stand out from your competitors. Accounting helps you to control your project. And there is a very big difference between accounting and finance. Not everyone knows the difference between accounting and finance, but finance helps you for the wealth maximization. This is a very important difference between accounting and finance. Budgeting helps you to be prepared for your project. Legal aspects. You know, some people are thinking that legal is to solve the problems, but frankly speaking, legal is to avoid their problems. HR helps you headhunt the best talents in your industry to serve your objectives. Key performance indicators. Which factors are key for the project success? For every industry, there are thousands of KPIs, but which ones are important for your success? You should study them to know how to control them. Pricing strategies. A lot of pricing strategies. You have to study them to know which one is suitable for your practice. Not all of them are suitable. Entrepreneurship can help you be the next healthcare Steve Jobs. Digital marketing. Digital marketing is one of the most demanded practices in the world right now. hundreds of specialties. By the way, everyone says that I know about digital marketing, but in reality, this is not the case. So you should know about digital marketing to know what is happening. Here are the winners. The registration numbers are here, by the way. The only know, this is a blind selection. The only one who knows these numbers are Mr. Fadi in the booklet. Please check the numbers with Mr. Fadi to give you the prize. But we have another gift for everyone, by the way. And anyone who has a new clinic is entitled for one week free social branding from our company. A gift for everyone is a very important startup just started last month called Touch Concierge. Do you know the Hotel Concierge here? The Hotel Concierge here gives you many services for free. And here, Touch Concierge is a healthcare concierge for healthcare professionals. They say that anything is possible. 3 important services from their side. 24/7 call center. I don't know if there is someone have a 24/7 call center except some few hospitals. Free website. Free booking system. Free photo sessions. Free video shooting. Free marketing tools. Free training, soft and hard skills. Free legal consultations. The free accounting system. Plus much more. Free design services. Plus much more. Why we are saying about this startup? Frankly speaking, this icon guy for ice hockey, he is saying that ice skate to where the puck is going to be, not where the puck has been. And all of us should do the same thing. We should go to the direction of the puck. We should not stay in our place and stay the puck to come for us. We should go to where the puck is going to be. This is the website. Register and stay tuned. Maybe more is coming. This takeaway message is a very important message. It's the most important slide in my presentation. Let's read it together. Offering high-quality treatments is not enough to build a successful business in the very demanding and the competitive field of medical practice. Besides assuring high-standard medical practice services, you need to think and act as a business person, develop and follow a sustainable and profitable business model. Patient, think and act as any other industry's customer. Hence, the operational setup needs to be adapted to cater for their needs and expectations. Healthcare professionals should empower their knowledge to develop their business acumen and make their practice thrive. Thank you very much again, and thank you for Dubai people.
Thanks, Dr. Muhammad Dessouky, for the presentation. And if you have from your audience any question to the speaker. Okay, thank you. And now we're going to move to the next presentation by Mrs. Khulud Yassin. She's a burn nurse, and we would like to highlight the important role of the nurses as a backbone in burn care. And she's representing the nurses in the Gulf region. She's a registered nurse at the King Abdulaziz Medical City burn units. She will talk about the role of nursing care in pediatric patients.
Good afternoon, everybody. My name is Khulud. I'm the burn and plastic coordinator in GHA in Jeddah, Saudi Arabia. Today, I'm going to do a presentation about nursing care of burn pediatric patients. Burns are potentially catastrophic injuries that disproportionately affect non-Western countries. An estimated 180,000 deaths every year are caused by burns that vast majority occur in low and middle income countries. Non-fatal burn injuries are a leading cause of morbidity. Burns occur mainly in the home and workplace. The prevalence of burns among infants in our hospital is high, and preventive measures must be implemented to decrease the occurrence of burns in this age of group. Electrical burn cause significant morbidity and mortality and can be prevented easily. The most of the electrical injuries can be prevented by education, policy implementation, and use of safe PPE. What is a burn care nurse? Burn care nurses are nursing professionals who primarily care for individuals who have suffered burn injuries. These nurses assist burn victims throughout all stages of their recovery, from initial trauma treatment to recovery to any post-trauma therapy that may be required. Nursing professionals working in the specialty should have a broad range of clinical skills in critical care, pain management, psychological counseling, triage, and trauma recovery. What are some burn care nurse duties? Burn care nurse, she will be able to evaluate, dress, and monitor different kinds of burn injuries, stabilize severity of burn patients, work as a part of interdisciplinary team, which includes doctors, nurses, psychological, occupational therapy, and help to maintain the patient's comfort, evaluate pain levels, pay close attention to the patient's psychological well-being, and determine whether they require any mental health intervention, educate patients and their families and the wider community about techniques that can be used to prevent burns, administer medication and topical ointment, educate the families and caregivers of patients in wound care of various kinds of burns. How burns occur in children? Each year, approximately 250,000 children aged from 0 to 17 years are burned severely enough to require medical attention. The nature and the developmental stage of children are associated risk for injuries includes burns, and the majority of burns happen before the age of 5 years old. The advancement of the nursing rules in pediatric burn care can be categorized into the three major areas. These three major areas are acute, rehabilitative, and psychological. Special attention must be paid to estimated of total body surface are fluid resuscitation and metabolic demands and adequate analgesia and sedation. Long-term effects involve scar management and psychological support to the child and their family. Compassionate, comprehensive burn care is accomplished by a multidisciplinary team offering healing in the acute setting and preparing the child and family for long-term treatment and care. So, as we mentioned earlier, the three stages, which include for the pediatric nurse, first stage is acute care setting, which include stabilization of the airway, multi-organ, fluid management, assessment of wound, medications, and antimicrobial and pain. And the rehabilitation, rehabilitative stage will be include dressing change management, acute inpatient or as outpatient, physical therapy, skin care and scar care, skin grafting, wound site, and dietary consideration. About the last stage, which the psychological, post-traumatic stress disorder parents and child related to dressing change, child related to the trauma, views of the burn, and issues of body image, inability to process adapting to the life back outside the hospital, cultural is consideration in this stage. So the recommendation for the practice and advanced research, the nurse must be aware of comprehensive of nursing rules in pediatric burn care to give the most holistic evidence-based care and to ensure the highest quality of care and life for the patients with more research into adult and pediatric burn care, the trend of higher quality care given to the burn patients. Nurses are Pivotal in the treatment of the burns by providing care, including local burn care, intensive care for severe burns, and inhalation burns, burns care instruction and prevention, educate and outreach. So thank you to listening to my presentation. Any question? Thank you.
Thanks, Mrs. Khulud Yassin, for a nice presentation. Thanks for all of you, audience, who was last till the last minutes of the conference. And thank you for your presence. And we'll see you in the upcoming conference next year. Thanks, Dr. Marwan. Thanks all the audience, and the speakers will be all highlighted all the nice presentation and share their experience. And thanks for the audience to be around and share with their questions and interactions. Thank you. Okay, we conclude the conference. Thank you.
I sincerely appreciate your attention, and that brings this conference to an end. I would like to thank each one of you for taking out your time and patience and making this event a remarkable one. Thank you so much. This is Sanjeevani Sharma signing off.
Your presentation, and thanks for all the team, supportive, and did a great job in logistic support for the conference. Thank you.